Welcome to the deep dive. Today, we're peeling back the layers of our largest organ, the skin, to truly understand its pharmacology.
Yeah, it's a big topic.
It really is. We're talking about everything from, why that acne cream works maybe, to how advanced therapies can help heal serious wounds without leaving a trace. Our goal, it's to give you a shortcut to mastering this information, arming you with the kind of insights that, truly well-informed professionals rely on.
Right.
We want you to grasp not just what treatments exist, but the deep why behind them.
Precisely. And we're drawing from some extensive foundational material, including a real cornerstone text like GOODMAN and GILMAN's The Pharmacology, to uncover that intricate relationship between the skin and the medications we apply to it.
Okay.
We'll explore everything from its, microscopic barriers right up to the cutting-edge targeted therapies for complex conditions, helping you understand the sophisticated dance, really, that determines how these drugs function and their profound implications for your health.
We'll look at how medications applied to the skin can act locally, treating disorders right there, or even work systemically, delivering drugs to other parts of the body.
Exactly.
You'll see the remarkable science that makes topical therapies effective and safe, and crucially, why understanding the skin's basic biology is absolutely foundational to, appreciating dermatological care at that elite level.
Couldn't agree more. The physiology is key.
So let's begin with the star of our show. The skin itself. It's far more than just a covering. It's a dynamic, a multi-compartment organ, your body's primary interface with the external world. And that crucial front line is a layer you might, consider dead.
Yeah.
But it's anything but inert.
Yeah.
The stratum corneum.
Indeed. The stratum corneum, it's often described as the non-living portion of the epidermis because it's composed of these flattened dead cells, right?
Right.
But paradoxically, it's absolutely vital.
Vital.
Its primary role is to act as the major barrier. It prevents drugs from entering the body too easily, which is a critical safety feature. And, equally important, it prevents excessive water loss from within. That maintains your body's hydration.
So, like a shield.
Think of it exactly like that. Your body's incredibly selective, remarkably waterproof, and surprisingly intelligent outer shield.
And this shield isn't uniform across your body, which I imagine is a key detail influencing how any topical medication will behave.
Absolutely. Its thickness varies dramatically.
Yeah.
You have your thickest areas like the palms of your hands and the soles of your feet. They're built for heavy-duty protection, right? So they're quite resistant to drug penetration.
Makes sense.
Then there's the general body skin, which is somewhat thinner. As you move to areas like the face and behind the ears, what we call the postauricular area, the skin becomes even thinner.
Good.
And finally, the thinnest, most permeable areas are like the eyelids and the scrotum.
Right. Very thin there.
This natural variation directly dictates where and how specific topical medications are used. For example, a potent steroid on your eyelid would have a dramatically different and potentially harmful effect compared to the same steroid applied to your forearm, simply because of this difference in barrier thickness.
That's a huge factor. Okay, so beneath that protector stratum corneum lies the vibrant, the truly living part of the epidermis.
Exactly. That's the metabolically active layer, roughly 100 micrometers thick. It comprises the stratum basal, stratum spinosum, and stratum granulosum. This is where the core cellular activity of the skin truly happens.
And this living epidermis, you're saying it's a bustling hub of specialized cells, each playing an essential role.
It really is. You have the melanocytes, for instance. They're responsible for producing pigment, giving your skin its color, and crucially, protecting you from harmful UV radiation. There are also neuroendocrine Merkel cells involved in your sense of touch. And perhaps most fascinating for our discussion today, it houses critical immune cells. Think dendritic antigen-presenting cells, specifically epidermal Langerhans cells, along with other immune sentinels like gamma delta T cells.
Wow, so immune cells right there in the epidermis.
Constantly patrolling, yes. Surveying for threats, ready to kickstart immune responses right at the skin surface.
And the clinical relevance of this cellular complexity must be pretty profound.
It is. In a diseased epidermis, say in eczema or psoriasis, you'll observe an even greater infiltration of immunological cells, lymphocytes, polymorphonuclear leukocytes. What's truly insightful here, and key for pharmacology, is that these immune cells often become direct targets for applied drugs.
Ah, so the drugs can target them directly.
Exactly. This highlights how specific topical therapies can precisely interact with and modulate the body's immune response within the skin. It offers a sophisticated advantage for treating inflammatory conditions locally, often without needing to impact the entire body systemically.
Journeying deeper then, beneath the epidermis, we encounter the dermis. This is the layer that gives skin its strength.
Precisely. This robust layer is the true workhorse for providing mechanical strength and flexibility to your skin. It's primarily composed of fibroblasts, those specialized cells that produce the extracellular matrix.
Right, the matrix.
Which is a rich network containing collagen for tensile strength, proteoglycans and glycoproteins that help organize the tissue and retain water, and elastic fibers, particularly concentrated in the upper dermis, giving skin its characteristic bounce and resilience.
But it's not just structural, right? There are other cells involved.
Oh, definitely. Beyond its structural role, the dermis is teeming with cells that can be direct drug targets. Think mast cells, which are permanent residents and rapid producers of many inflammatory mediators, and also infiltrating immune cells that produce various cytokines. Crucially, the dermis contains dense, intricate networks of nerves, blood vessels, and adnexal structures like hair follicles and sweat glands. Now, the superficial capillary plexus, located right at the interface between the epidermis and dermis.
That junction area.
Exactly. That's the primary site where most systemic absorption of cutaneous drugs occurs.
Ah, so that's how things get into the bloodstream from the skin.
Primarily, yes. This is a critical point. It means a drug applied to the skin, if designed effectively, can indeed enter the bloodstream and influence other parts of the body. It opens up possibilities for transdermal drug delivery.
What about hair follicles? Do they play a role?
They do offer a lipid-rich pathway for drug absorption, but they represent only a tiny fraction, about 0.1% of the total skin surface area.
Oh, really? That's small.
Yes. So it makes them a relatively minor route for overall absorption. You wouldn't expect most drugs to use your hair follicles as a primary entry point.
Interesting. And sweat glands?
Sweat glands aren't known for significant drug absorption, but some drugs, like the antifungal griselfulvin, can actually be excreted through them.
Wow, okay. And finally, beneath the dermis.
Below the dermis is the hypodermis, or subcutaneous tissue. This acts as a crucial layer for insulation, cushioning against physical impact, and serving as a vital energy reservoir due to its significant fat content.
So now that we have a clearer picture of the skin's complex architecture, the next big question is, how do medications actually navigate through these layers to reach their target? It's clearly not as simple as just spreading on a cream.
No, not at all. There are very specific pathways and properties that determine a drug's effectiveness.
So what's the main route?
Percutaneous absorption, the process by which drugs pass through the skin, primarily occurs via a winding intercellular route.
Intercellular, between the cells.
Exactly. Imagine the drug having to navigate a complex maze between the tightly packed cells of the stratum corneum, like squeezing through the mortar between bricks in a wall. This tortuous pathway is the dominant mechanism for most topically applied substances.
And this leads to, I guess, a crucial principle in skin pharmacology.
It does. Passage through the stratum corneum is the slowest rate-limiting step for how much drug actually gets through.
The bottleneck.
Precisely. It acts as the primary bottleneck in the entire absorption process. If a drug struggles to overcome this tough outer layer, its overall topical effectiveness will be significantly limited.
Are there other ways through? Minor pathways?
Yes. While the intercellular route is paramount, there are minor pathways. Drugs can also pass directly through the cells themselves, that's the transcellular route, or utilize skin appendages like hair follicles, the appendageal route.
But they don't contribute much.
Much less, comparatively. These routes play a much smaller role in overall absorption, really reinforcing the stratum corneum's role as the main gatekeeper.
So for a drug to be effective topically, it needs specific properties to get past that gatekeeper.
Absolutely. Specific properties are needed to navigate this formidable barrier. First, its molecular size is key. It generally needs a low molecular mass, typically 500 Daltons or less.
500 Daltons, okay.
Larger molecules find it incredibly difficult to penetrate the compact structure of the stratum corneum.
What about solubility?
Second, the drug needs adequate solubility in both oil and water. Achieving this balance is crucial.
Why both?
Well, if it's too water-soluble, it won't effectively cross the lipid-rich stratum corneum. If it's too oil-soluble, it might get trapped within the skin layers and fail to reach deeper targets where it needs to act. It's a balancing act.
Okay.
Third, a high partition coefficient is generally desirable. This means the drug will selectively move from its vehicle, the cream, ointment, or gel it's formulated in, and preferentially partition into the lipid-rich stratum corneum itself. it effectively chooses to enter the skin barrier.
This balanced solubility sounds like a challenge for drug developers.
It is a significant challenge because, with the exception of very small particles, water-soluble ions and highly polar molecules don't penetrate an intact stratum corneum significantly.
So hydrophilic drugs have a tough time.
A major uphill battle. Often, in clinical practice, the exact amount of drug absorbed systemically isn't precisely measured. Instead, the primary focus remains on achieving the desired clinical outcome like reduced inflammation or clear skin demonstrating the drug's local effect.
Beyond the drug's own chemistry, are there ways to boost absorption?
Oh, definitely. We have methods to actively enhance absorption. A hydrated stratum corneum allows for significantly more absorption.
Hydration is key.
Absolutely. This is why occlusive vehicles like thick ointments are often chosen. They trap moisture on the skin's surface, increasing hydration. Similarly, physical occlusive measures like plastic films or wraps for the hands and feet, or even shower caps for the scalp are used to create a more hydrated environment, promoting drug penetration.
But occlusion isn't always good, right? There are downsides.
You're right. While occlusion can be incredibly beneficial for boosting absorption, it's not without its drawbacks. Creating that warm, moist, occluded environment can, unfortunately, lead to increased bacterial growth, potentially resulting in infections like folliculitis.
Ouch.
Yeah, and it can also cause maceration, which is a softening and breakdown of the epidermis, making the skin more fragile and vulnerable.
Are there more, maybe active ways to enhance absorption?
Yes, there are more active and sophisticated enhancement methods. Technologies like applying heat, ultrasonic energy through a process called photophoresis, or even electric currents known as iontophoresis. These can significantly increase percutaneous absorption by altering the skin barrier.
Like forcing the drug through.
In a controlled way, yes. And minimally invasive microneedling, which creates tiny temporary channels in the skin, and fractional or ablative lasers, which remove microscopic columns of skin, can also dramatically increase drug penetration by temporarily bypassing the stratum corneum's formidable barrier function.
Now, one of the big advantages of getting drugs through the skin, transdermal delivery, is bypassing the liver, right? Avoiding that first-pass metabolism.
Exactly. Transdermal drug delivery conveniently bypasses hepatic first-pass metabolism. This means the drug doesn't have to go through the liver immediately after absorption, where it might be significantly broken down before reaching its intended target. This can be a huge advantage for certain medications, improving their bioavailability.
But the skin itself can metabolize drugs.
It can. This doesn't mean a complete escape from metabolism. The epidermis itself is metabolically active. It contains various enzyme systems capable of metabolizing drugs that reach this compartment. For instance, a specific CYP isoform, CYP26A1, plays a crucial role in metabolizing retinoic acid, precisely controlling its levels right there in the skin. Furthermore, human keratinocytes, the main cells in the epidermis, also possess transporter proteins that influence the influx of certain xenobiotics, like organic anion-transporting polypeptides, or OATP, or their efflux, pushing them back out, through systems like multi-drug resistance transporters and P-glycoprotein.
So the skin has its own processing system, and genetics must play a role there too.
Absolutely. This intricate local processing raises an important question. How do genetic variants of these enzymes, say those regulating methotrexate's cellular influx and efflux, influence drug toxicity and effectiveness, particularly as we see in patients with conditions like psoriasis? Understanding these individual genetic differences is increasingly crucial for moving towards truly personalized medicine in dermatology.
And I heard about a reservoir effect.
Yes. What's also quite fascinating here is that a drug can partition into the stratum corneum and form a reservoir.
So it stays there.
It does. It means the drug can be stored within that outermost layer, continuing to diffuse slowly into the rest of the skin and potentially even into the systemic circulation long after the topical application is stopped. This reservoir effect can provide a prolonged duration of action, allowing for less frequent application of some treatments while maintaining therapeutic levels.
That's clever. So pulling this all together with this detailed understanding of skin structure and how drugs get through, how does this knowledge guide practical decisions? How do doctors tailor treatment?
Well, when recommending topical medications, practitioners must weigh multiple factors for optimal outcomes. It's not just picking a drug off the shelf.
Right.
This includes determining the proper dosage and frequency of application, which isn't always intuitive. They must also assess the extent and condition of the skin's permeability barrier. Is it intact, or is it compromised by a disease like eczema or psoriasis?
That makes a difference in absorption.
A huge difference. Patient age and weight are also critical considerations. The physical form of the preparation being applied, whether it's an ointment, cream, or gel, is a vital choice for effectiveness and, importantly, patient experience. And finally, practitioners must consider whether intralesional injection directly into a lesion or even systemic administration throughout the body would be more appropriate for the specific condition and its severity.
You mentioned age being critical. How does a child's skin differ pharmacologically?
It's fundamentally different with profound implications. Children have a significantly greater ratio of surface area to mass compared to adults.
More surface area for the same weight, basically.
Exactly. This means that the same amount of topical drug applied over a given area can lead to substantially greater systemic exposure in a child. This drastically increases their risk of systemic side effects. And preterm infants, in particular, have a markedly impaired barrier function because their epidermis hasn't fully keratinized yet. This makes them exceptionally vulnerable to systemic absorption, requiring extreme caution with any topical medications.
And skin diseases themselves affect the barrier.
Yes, many dermatological diseases inherently compromise the skin's barrier function. Conditions like severe eczema, psoriasis, or burns, for example, involve a disrupted barrier. This directly leads to increased percutaneous absorption of topically applied drugs,
So the drug gets in more easily.
which can dramatically change treatment strategies. It might necessitate adjustments to medication strength and frequency, and it can increase the potential for systemic side effects, requiring much more careful monitoring.
This brings us to the drug vehicles. This seems like a really crucial choice, affecting delivery and how the patient feels about using it.
Absolutely. This is truly where the art meets the science in dermatological treatment. The vehicle, the base in which a drug is formulated, dramatically impacts its delivery, its effectiveness, and crucially, your experience as a patient.
Okay, let's break down the common ones. Ointments first.
Right. First, consider the ointment. This is a drug, either solid or liquid, dispersed in a non-aqueous base, often white petrolatum. Its nature allows it to form a protective oil film on the skin.
Like a barrier.
Exactly. It helps it spread easily and significantly slows water evaporation from the skin's surface. This provides moderate to high occlusion, enhancing skin moisture, which, as we said, can increase drug penetration.
But they're greasy.
That's the main drawback. They're inherently greasy and can stain clothes, making them generally unsuitable for intertriginous areas, those skin folds like the armpits or groin, where greasiness can lead to irritation or folliculitis.
Okay, what about creams? They seem more popular.
Yes, creams are a popular choice. They're formulated as an oil and water emulsion. Creams tend to concentrate the drug at the skin surface after application. They spread and remove easily, don't feel greasy like ointments, and offer moderate occlusion.
So less occlusive than ointments.
Generally, yes. Because they contain water, they require humectants to stay moist and preservatives to maintain stability and prevent microbial growth. Creams are highly versatile and suitable for most body locations.
Then there are gels. What's the story there?
Gels are typically water-soluble emulsions with a gelling agent. They concentrate the drug at the surface after the water evaporates, providing a quick drying formulation. Gels are non-staining, greaseless, and usually clear, which makes them cosmetically appealing for many people.
Any downsides?
They can be drying, especially if they have a high alcohol content. They're generally best for the scalp and other hairy locations, and they offer relatively low occlusion. What's particularly innovative are newer formulations like microspheres or microsponges incorporated into gels.
Oh, what do they do?
They can enhance drug solubilization, improving topical penetration while simultaneously reducing skin irritation. A clever balance.
And finally, lotions, solutions, foams, sprays. That's a broad category.
It is. These formulations can be either aqueous or alcoholic. They leave very little residue on the skin, making them ideal for the scalp or other hairy areas, and often provide a pleasant cooling effect as they evaporate.
But they can dry the skin.
Yes, the potential downsides include drying or a burning sensation if the alcohol content is high. Foams, while convenient for application and often preferred for larger hairy areas, are generally more expensive due to their complex delivery systems, and they offer essentially no occlusion.
And there are even more specialized delivery systems, too.
Oh, yes. Beyond these common forms, medications can also be delivered via specialized systems like medicated tapes or patches, in powders, emollients, lacquers for nails, and even highly advanced systems like liposomes and nanoparticles. Each of these is designed to optimize drug delivery for specific conditions and body areas, showcasing the real ingenuity in dermatological formulation science.
Okay, fantastic overview of the skin and how things get through it.
Yeah.
Now let's pivot to the specific classes of medications dermatologists use. We're moving into the practical toolkit, starting with a real workhorse. Glucocorticoids. Steroids.
Yes, glucocorticoids are invaluable in dermatology due to their potent immunosuppressive and anti-inflammatory properties. This makes them effective for a vast array of skin conditions.
How are they usually given?
They can be administered locally via topical and intralesional routes for targeted action, or systemically through intramuscular, intravenous, or oral administration for more widespread or severe issues. While their detailed molecular mechanisms are complex, the key takeaway is their wide-ranging influence on immune and inflammatory pathways at multiple cellular and molecular levels. They essentially dampen an overactive immune response.
And topical steroids, they aren't all the same strength, are they?
Not at all. Topical glucocorticoids are meticulously grouped into 7 classes, ranging from the most potent, class 1, down to the least potent, class 7.
How is that potency measured?
Traditionally using a vasoconstrictor assay, which assesses how much the skin blanches or whitens under occlusion due to blood vessel constriction. But it's also measured by their ability to suppress erythema and edema from induced inflammation, or by their effect on psoriatic lesions in a psoriasis bioassay. This systematic classification is critical for clinicians to choose the precise strength needed for a given condition and body area.
And they work well for many conditions.
Many inflammatory skin diseases, yes. Things like eczema or psoriasis respond remarkably well to topical or intralesional glucocorticoids. The selection of the specific steroid hinges on its potency, the particular body site involved, remember the thickness variations, and the severity of the skin disease.
Right.
A common strategy involves using a more potent steroid initially to rapidly bring the condition under control, then stepping down to a less potent agent for maintenance as improvement occurs. This approach balances efficacy with minimizing potential side effects.
How often do you typically need to apply them?
Here's a crucial practical insight. Twice-daily application is usually sufficient for most topical glucocorticoids. Applying them more frequently generally doesn't improve the response, so more isn't necessarily better.
Yeah, sure.
For conditions like atopic dermatitis, research shows once-daily application of moderately potent to very potent corticosteroids is just as effective as twice daily.
Right.
And that simplified regimen can significantly improve patient adherence, making it easier for people to stick to their treatment plan.
Are there rules about where you can use certain potencies?
Yes, definitely. A general rule of thumb is that only non-fluorinated glucocorticoids should be used on sensitive areas like the face, armpits, or groin. These areas absorb more readily and are more prone to side effects from the stronger fluorinated compounds.
Okay.
And intralesional preparations like insoluble triamcinolone acetyne and triamcinolone hexacetonide are specifically designed to solubilize gradually. This provides a prolonged duration of action ideal for stubborn, localized lesions like keloids or cystic acne.
But there are side effects to watch out for with topicals.
Absolutely. While highly effective, topical corticosteroids do come with potential side effects, particularly with prolonged use or on sensitive skin. These include skin atrophy, thinning of the skin, the development of striae or stretch marks, telangiectasias, visible spider veins, purpura bruising, and acneiform eruptions.
And the fluorinated ones on the face.
Specifically, fluorinated compounds should be avoided on the face as they can lead to puerperal dermatitis, an inflammatory rash around the mouth, and rosacea. Most importantly, the use of high-potency corticosteroids, chronic application, use over large body surface areas, or under occlusion can lead to hypothalamic pituitary adrenal HPA axis suppression.
That sounds serious.
It is. It's a systemic effect where your body's natural production of corticosteroids is disrupted, mimicking adrenal insufficiency. Needs careful management.
Can you give examples of the strongest and weakest?
Sure. From Table 75 to 3 in our source, some of the most potent Class 1 topical glucocorticoids include augmented betamethasone propionate in gel, lotion, or ointment, and clobetasol propionate, available in many forms: cream, ointment, gel, solution, foam, spray, etc. At the opposite end, the least potent, Class 7, is typically hydrocortisone, commonly available in 0.5% to 2.5% strength.
Okay. What about systemic steroids? When are they used?
Systemic glucocorticoid therapy, meaning oral or injectable forms, is generally reserved for severe or extensive dermatological illnesses. Cases where topical treatments are insufficient or where the disease has significant systemic involvement.
Like what kinds of conditions?
Think severe allergic contact dermatitis, like a widespread reaction to poison ivy, serious blistering diseases such as pemphigus vulgaris and bullous pemphigoid, certain forms of vasculitis, autoimmune connective tissue diseases, and neutrophilic dermatosis like pyoderma gangrenosum.
And long-term use is risky.
Paramount to understand that chronic administration of oral glucocorticoids comes with numerous and significant systemic side effects. These are powerful drugs impacting many body systems, and long-term use requires a careful, ongoing assessment of risks versus benefits with meticulous patient monitoring.
How are they usually dosed systemically?
Daily morning dosing with prednisone is generally preferred, though divided doses are sometimes used to enhance efficacy, especially for breakthrough symptoms. For chronic therapy, alternate day dosing is often preferred to reduce the cumulative side effects, with prednisone usually tapered to an every other day regimen as soon as practical.
What about really severe cases? Is there anything stronger?
Yes. For severe resistant cases like pyoderma gangrenosum, pemphigus vulgaris, SLE with multisystem disease, dermatomyositis, linear morphe intravenous pulse therapy with methylprednisolone sodium succinate is a potent option.
Pulse therapy. High doses.
Very high doses, typically. For pediatric patients, 15 to 30 milligrams per kilogram per dose, max 1,000 milligrams daily for 3 days. For adults, generally 7 to 15 milligrams per kilograms per dose, often 500 to 1,000 milligrams daily for 3 to 5 days.
And how are those given?
These infusions are usually given slowly over 2 to 3 hours. More rapid infusion has been linked to increased rates of hypotension, significant electrolyte shifts, and cardiac arrhythmias, underscoring the need for careful administration.
And just to reiterate, those systemic side effects depend on dose and duration.
Exactly. Most side effects are directly dependent on both the dose and the duration of therapy. Higher doses and longer courses generally lead to more pronounced and potentially serious adverse reactions, requiring close medical supervision.
Okay, let's move on from steroids. Another incredibly important class is retinoids, related to vitamin A, right?
Correct. Retinoids are a diverse class of natural and synthetic compounds that either exhibit vitamin A-like biological activity or bind to specific nuclear receptors for retinoids. Their ability to broadly influence cellular processes, from growth and differentiation to program cell death, makes them remarkably versatile therapeutic agents in dermatology.
And there are different generations of them.
Yes, the evolution of retinoids is a fascinating story of pharmaceutical refinement. The first generation includes natural compounds or close derivatives, like retinol, vitamin A itself, tretinoin, all-trans retinoic acid, isotretinoin, 13-cis-retinoic acid, and allitretinoin, 9-cis-retinoic acid. The second generation, often called aromatic retinoids, introduced compounds like acitretin and tretinate, designed for enhanced stability and specific actions. Then came the third generation, specifically engineered for optimized receptor-selective binding, tazarotene, bexarotene, adipoline.
And even a fourth.
And now, yes, a fourth generation represented by trifarotene, which further refines that receptor-selective binding, allowing for even more precise targeting of cellular pathways.
How do they actually work? What's the mechanism?
The profound power of retinoids stems from their ability to directly influence gene expression. They achieve their effects by activating two crucial families of nuclear receptors within cells: the retinoic acid receptors, RARs, and the retinoid X receptors, RXR.
To the steroid receptor family?
Yes, members of the steroid receptor superfamily, indicating a shared evolutionary pathway with other vital hormone signaling systems.
And it gets complex with different types of these receptors.
It does, truly intricate. Both the RAR and RXR families each have 3 distinct isoforms: alpha, beta, and gamma. These isoforms are expressed in unique combinations in different tissues and cells throughout your body, allowing for precise control.
So how does the binding work?
When a retinoid molecule binds to its specific receptor, the RXRs then form heterodimers they pair up. These heterodimers subsequently bind to specific DNA sequences called retinoic acid response elements, RXRs, in the cell's nucleus.
And that triggers gene changes.
Exactly. This binding then activates the transcription of genes whose products lead to both the desirable pharmacological effects and, unfortunately, the unwanted side effects often associated with retinoid therapy. It's a precise but powerful genetic orchestration, fundamentally altering cell behavior.
So different retinoids target different receptors for specific effects.
Precisely. This concept of receptor selectivity is key. Retinoids that primarily target ARRs like tretinoin, adapalene, and tazarotene predominantly influence cellular differentiation and proliferation.
Which is why they work for acne and psoriasis.
Exactly. Those are disorders fundamentally involving abnormal differentiation and proliferation of skin cells.
And the ones targeting RXRs.
In contrast, retinoids that primarily target RXRs, like bixarotene and allotritinone, predominantly induce apoptosis, or programmed cell death.
So they're used for things like skin cancers.
Yes. This makes them particularly valuable in conditions like cutaneous T-cell lymphoma, CTCL, and Kaposi sarcoma, respectively, where the therapeutic goal is to specifically trigger the self-destruction of malignant cells. It offers a more precise attack.
But these are potent drugs, so toxicity is a concern.
Definitely. While incredibly effective, retinoids, particularly systemic ones, come with a spectrum of potential toxicities that require careful management. Acute retinoid toxicity often mirrors the symptoms of vitamin A intoxication.
What kind of systemic side effects are we talking about?
They're diverse and can be quite widespread, reflecting their broad impact on gene expression. Common issues include very dry skin, nosebleeds due to dry mucous membranes, conjunctivitis, eye irritation, and reduced night vision. More severe, though less frequent, effects can involve hair loss, alopecia, alterations in serum lipids like cholesterol and triglycerides, changes in liver transaminases indicating liver stress.
Wow, quite a list.
Hypothyroidism, inflammatory bowel disease flare-ups, musculoskeletal pain, pseudotumor cerebri that's increased pressure around the brain, and even mood alterations. It underscores the need for close monitoring.
Does the side effect profile differ between retinoid types?
Interestingly, yes. RRR selective retinoids are more often associated with mucocutaneous and musculoskeletal symptoms. RXR selective retinoids tend to induce more physicochemical changes within the body.
But the biggest concern is birth defects, right? Teratogenicity.
Absolutely paramount. All oral retinoids are potent teratogens. This means they are absolutely contraindicated during pregnancy and must be used with extreme caution in females of childbearing potential due to the severe risk of birth defects. This is a non-negotiable safety warning, managed through strict risk management programs like IPL Edge for isotretinoin.
Okay, let's switch to topical retinoids. Applied to the skin, how do they work for acne?
For acne, through mechanisms still being fully elucidated, they correct abnormal follicular keratinization, that process leading to clogged pores. They also reduce the counts of Cutibacterium acnes, the bacteria implicated in acne, and help reduce inflammation.
So multiple actions.
Yes, this multi-pronged action makes them a cornerstone of acne therapy. They're first-line agents for non-inflammatory comedonal acne and often combined with other agents for inflammatory acne.
And they help with photoaging too, wrinkles and spots.
They do. Topical retinoids also significantly improve key features of photoaging, like fine wrinkles and mottled pigmentation. In the dermis, this is thought to be due to their inhibition of AP1 or activator protein 1.
What does AP1 do?
It's a transcription factor that normally activates matrix metalloproteinases in response to UV irradiation, which contribute to collagen breakdown and skin aging. So inhibiting it helps preserve collagen.
Okay. And in the epidermis?
In the epidermis, retinoids induce epidermal hyperplasia in atrophic, thin skin and reduce keratinocyte atypia, contributing to healthier, more resilient-looking skin.
What about side effects from topicals? Mostly local irritation.
Primarily, yes. The most common adverse effects of all topical retinoids are erythema, redness, desquamation, peeling, xerosis, dryness, burning, and stinging. The good news is these effects often diminish over time as the skin adapts, and they can be mitigated by using emollients alongside the retinoid.
And sun sensitivity.
Yes, patients may experience photosensitivity reactions, enhanced reactivity to UV radiation, and have a significant risk for severe sunburn. Diligent sun protection is absolutely critical.
Even though absorption is low, still cautious about pregnancy.
Right. While systemic absorption of topical retinoids is typically low and doesn't usually alter plasma vitamin A levels significantly, they are still generally not recommended for use during pregnancy as a precaution, given the known teratogenicity of the class.
Let's run through some specific topicals. Tretinoin, the original.
Yes, tretinoin, all trans-retinoic acid. It's notably photolabile, meaning it breaks down in light, so it should be applied once nightly for acne and photoaging. Importantly, benzoyl peroxide also inactivates tretinoin, so they shouldn't be applied simultaneously unless using specific advanced formulations.
Like microsphere formulations.
Exactly. Newer formulations with copolymer microspheres or pre-polymer 2 gradually release tretinoin, which reduces irritancy and makes it less susceptible to oxidation by benzoyl peroxide and photodegradation. It targets RAR alpha, beta, and gamma receptors, and typically has a moderate level of irritation. We could say plus tenare.
Adapalene, how's that different?
Adapalene, approved for acne vulgaris, shows similar efficacy to tretinoin. A significant advantage is that, unlike tretinoin, adapalene is stable in sunlight and in the presence of benzoyl peroxide.
So more flexible for combining therapies.
Right. It's also more lipophilic, allowing for rapid penetration through follicular openings, beneficial for targeting acne directly. Adapalene selectively targets RAR beta and gamma receptors and is associated with a lower irritation level, maybe just a plus sign.
What about triferritine, the newer one?
Triferritine is a fourth-generation retinoid approved for acne vulgaris on the face and trunk. It stands out due to its highly selective binding to RAR gamma receptors, which are abundant in skin. Human studies haven't found a pregnancy risk with topical use, though animal studies at very high doses showed fetal adverse effects, so caution is still advised. Its irritation level is also generally low, a plus N.
Tazartine seems stronger, used for psoriasis too.
Yes, tazartine is approved for a broader range, including psoriasis, photoaging, wrinkles, and acne. Tazartine gel, applied once daily, can be used alone or combined with other meds like topical corticosteroids for localized plaque psoriasis. Interestingly, topical corticosteroids can actually improve efficacy and reduce common side effects like burning and itching with tazartine.
But it's more irritating.
It targets RAR alpha, take-beta, and tagammam. But yes, it's known for having the highest level of irritation, maybe plus. Patient education and comfort management are critical.
Alotretinoin, that binds all receptors.
Allotretinoin, 9-cis-retinoic acid, is distinct, yes. It binds all types of retinoid receptors, both RARs and RXRs. It's approved for treating cutaneous lesions of Kaposi sarcoma, with application often titrated up slowly as tolerated. A critical warning. Allotretinoin should not be applied concurrently with insect repellents containing DEET, because it may increase DEET absorption, and if significant absorption occurred in a pregnant woman, the gel could cause fetal harm. Its irritation level is moderate, plus EAT.
And Bexardine, for CTCL.
Finally, Bexartine gel is approved for early stage, IA and IB, cutaneous T-cell lymphoma. Its application is carefully titrated up over several weeks to improve tolerance. Similar to allotretinoin, concurrent application with DEET is not recommended, and it may cause fetal harm if used during pregnancy. Bexartine selectively binds RXR alpha, beta, and gamma, and typically has a moderate to high irritation level, plus.
Okay, now for the systemic retinoids. Taken orally. Reserved for tougher cases.
Yes, systemic retinoids are powerful medications reserved for more challenging and widespread dermatosis. They are FDA approved for treating severe recalcitrant forms of acne, extensive psoriasis, and cutaneous T-cell lymphoma.
But used off-label for lots of other things too.
Absolutely. Their utility extends off-label to a wide array of conditions. Various forms of ichthyosis, Darrier disease, pityriasis rubra pilaris, rosacea, hidradenitis suppurativa, chemoprevention of certain malignancies, lichen sclerosis, subacute lupus erythematosus, and discoid lupus erythematosus. They have a broad impact.
And the absolute contraindication is pregnancy. Cannot stress that enough.
Cannot stress it enough. Systemic retinoids are unequivocally contraindicated for women who are pregnant, planning to become pregnant, or breastfeeding due to their extreme teratogenicity. No safe dose exists.
Are there other relative contraindications?
Yes, where caution and careful monitoring are required. These include patients with leukopenia, low white blood cells, alcoholism, hyperlipidemia, hypercholesterolemia, hypothyroidism, and significant liver or kidney disease, as these can increase the risk of adverse effects.
Let's talk toxicity and monitoring again for systemics. What are the acute issues?
Acute retinoid toxicities often involve mucocutaneous issues. cheilitis, severely chapped lips, xerosis, dry skin, blepharoconjunctivitis, eye inflammation, cutaneous photosensitivity, photophobia, light sensitivity, myalgia, muscle pain, arthralgia, joint pain, headaches, alopecia, hair loss, nail fragility, and increased susceptibility to staph infections. Some patients might develop a retinoid dermatitis with widespread redness, itching, and scaling.
Any rare but serious ones?
Yes. Rarely, patients might develop pseudotumor cerebri, especially if systemic retinoids are combined with tetracyclines. Bony changes can occur after chronic high-dose use, including diffuse idiopathic skeletal hyperostosis, DIS syndrome, premature epiphyseal closure in growing children, and other skeletal abnormalities.
And the teratogenicity is managed with programs like IP-UDGE for isotretinoin.
Precisely. In the U.S., prescribing isotretinoin is strictly regulated via the IP-ELF system. It requires meticulous monitoring, patient education, multiple negative pregnancy tests, and the use of 2 forms of contraception to prevent pregnancy.
What about lab monitoring?
Elevation of serum lipids, triglycerides, cholesterol, is the most common lab abnormality requiring regular checks. Less common issues include elevated liver enzymes, decreased thyroid hormone levels, and leukopenia. Monitoring for acitretin and bexarotene is more intensive, usually involving baseline lipids, liver enzymes, and a CBC, with monthly checks for the first 3-6 months, then every 3 months. Thyroid function testing is added for bexarotene.
Isotretinoin needs less monitoring.
For acne in otherwise healthy patients, yes, less frequent lab monitoring is required, and a CBC isn't typically needed unless there are other concerns.
And pregnancy tests are mandatory before and during treatment for women.
Absolutely. For females of childbearing potential, 2 negative pregnancy tests are needed before starting acitretin or isotretinoin. Bexarotene requires 1 negative test within the week prior. Monthly pregnancy tests are mandatory throughout treatment.
Let's look at specific systemic agents. Isotretinoin for severe acne.
Yes, isotretinoin is FDA approved for recalcitrant and nodular acne vulgaris. It shows remarkable efficacy, often inducing prolonged remissions after a single course. Clinical effects are usually seen within 1-3 months. Maximum effect sometimes takes 3-6 months. About a third of patients might relapse, usually mildly, within 3 years.
Does how you take it matter? With food?
Systemic absorption is improved when taken with a high-fat meal. There are newer formulations like Lidose, a drug-lipid mixture, or micronized versions that can be taken without regard to meals, offering more convenience. Non-Lidose forms do require a high-fat meal for best exposure. Its half-life is 10-20 hours, and it doesn't have clear receptor affinity like some others.
Acitretin for psoriasis. What's the big warning there?
Acitretin is approved for cutaneous manifestations of psoriasis. Clinical effect starts around 4-6 weeks, full benefit at 3-6 months. Half-life is about 50 hours. But here's the profoundly crucial point. When combined with alcohol, acitretin is converted in vivo to etretinate.
And etretinate has a very long half-life.
Extremely long, 80 to 160 days. We don't know how much alcohol triggers this, and it could be from hidden sources like mouthwash or cough syrup. Therefore, female patients of childbearing potential absolutely must avoid pregnancy for a full 3 years after receiving acitretin to prevent severe birth defects. It binds RAR-alpha, deodita, and afamine.
3 years. Wow. Okay, bexarotene systemically. Also for CTCL.
Yes. Bexarotene selectively binds RXRs. Oral formulations are approved for refractory CTCL. It reportedly induces apoptosis of malignant cells. Since it's metabolized by CYP334, inhibitors like certain antifungals, antibiotics increase its levels, while inducers like rifampin, certain seizure meds, decrease levels.
More side effects with this one.
Side effects are more common than with other retinoids, including a higher incidence of significant lipid abnormalities and hypothyroidism due to suppression of TSH gene expression. Also, pancreatitis, leukopenia, GI symptoms. Thyroid function must be measured before starting and periodically. Half-life is 7-9 hours, binds RXR-alpha, DAVETA, gamma.
Okay, moving beyond retinoids, what about other vitamin analogues, like vitamin D?
Yes, calabitrine is a topical vitamin D analog specifically approved for the treatment of psoriasis.
How does that work?
It exerts its effects through the vitamin D receptor in skin cells. When calcipotriene binds, the drug receptor complex partners with RXR-alpha and binds to vitamin D response elements on DNA. This increases the expression of genes that modulate epidermal differentiation and inflammation, ultimately improving psoriatic plaques by normalizing cell growth and reducing redness and scaling.
How is it used?
Generally applied twice daily to psoriatic plaques on the scalp or body. It's often combined effectively with topical corticosteroids, which help reduce the irritation calcipotriene can sometimes cause.
Any major risks?
A key concern is potential hypercalcemia, high blood calcium, and hypercalciuria, high urine calcium, if the cumulative weekly dose exceeds the recommended 100 grams. Thankfully, these effects usually resolve quickly after stopping the drug. It can also cause irritation around the lesions, perilesional irritation, and mild photosensitivity.
Any interactions?
It may be inactivated by concomitant use of acidic topical agents, like salicylic acid or lactic acid, so combining needs caution. Beyond psoriasis, it's been used off-label for morphea, vitiligo, congenital ichthyoses, and even with 5-fluorouracil for actinic keratosis.
What about beta-carotene, the vitamin A precursor?
Yes, sextishan found in green and yellow vegetables is mostly known as a supplement or food coloring, but it has a specific dermatological application.
Which is?
Dietary supplementation with beta-carotene is used to reduce skin photosensitivity in patients with erythropoietic protoporphyria, a rare genetic disorder causing extreme light sensitivity.
How does it protect from light?
The exact mechanism isn't fully established, but it's thought to involve an antioxidant effect, decreasing the production of harmful free radicals or singlet oxygen within the skin. Essentially, it acts like an internal photoprotective agent.
Now let's talk about actually using light for therapy. Photochemotherapy. Sounds futuristic.
It does, but it's a very real and effective therapy. Phototherapy and photochemotherapy are sophisticated methods using UV or visible radiation to induce a therapeutic response. Phototherapy is light alone. Photochemotherapy combines light with an exogenous photosensitizing drug.
What's the drug for?
It makes the skin more reactive to the light, amplifying its effects.
But this means you have to be careful about other sun-sensitizing drugs the patient might be taking.
Absolutely critical. Patients undergoing these therapies must be rigorously monitored for concomitant use of other photosensitizing medications. Things like phenothiazines, thiazides, sulfonamides, NSAIDs, sulfonylureas, tetracyclines, benzodiazepines.
That's a lot of common drugs.
It is, and it raises an important question. How aware are patients of the cumulative photosensitizing effects of all their various medications, especially when prescribed by different doctors? It's a serious patient safety challenge.
We need to understand the UV spectrum first, right? UVA, UVB.
Exactly. UV radiation is subdivided into UVA1, 340 to 400 millimeters, UVA2, 320, 340 millimeter, UVB, 290, 320 millimeters, and UVC, 100 to 290 millimeters. UVC is mostly absorbed by the ozone layer, thankfully. Both UVA and UVB exposure can cause sunburns, contribute to photoaging, and play a role in skin cancer.
Which one causes sunburn more?
UVB is the most erythrogenic, redness-causing, and melanogenic, tanning-causing. It's the main action spectrum for sunburn, tanning, skin cancer, photoaging, and importantly, cutaneous vitamin D synthesis.
And UVA?
UVA is only about 1,000th as erythrogenic as UVB, but it penetrates more deeply into the skin. It contributes substantially to photoaging and photosensitivity diseases. What's insightful is that UVA can also penetrate clouds and glass, meaning exposure happens even in shade or indoors.
Oh, didn't know that. And they both suppress the immune system.
Both UVA and UVB cause photoimmune suppression, an effect that is cleverly utilized therapeutically to calm overactive immune responses in certain dermatological conditions.
Okay, let's talk about PUVA. Psoralens and UVA.
Yes, PUVA is one of the most established and powerful forms of photochemotherapy. It combines UVA light with photosensitizing compounds called psoralens. Orally administered methoxysaline, 8-methoxypsoralen, followed by controlled UVA exposure, is FDA approved for vitiligo and psoriasis. It's also used off-label for other inflammatory or lymphoproliferative skin disorders.
What are psoralens chemically?
They're lipophilic, naturally occurring furocoumarins found in some plants, though synthetic versions are available. The action spectrum for PUVA is between 320 and 340 millimeters.
How do they work with the light?
Psoralens intercalate into the DNA strand. They insert themselves between the base pairs. When exposed to UVA, two distinct photoreactions occur. Type I reactions are oxygen-independent, involving photoaddition of psoralens to pyrimidine bases in DNA, forming crosslinks. Type II reactions are oxygen-dependent, involving energy transfer to molecular oxygen, creating reactive oxygen species.
And this helps skin conditions how?
Through incompletely understood mechanisms, these phototoxic reactions stimulate melanocytes, for vitiligo repigmentation and induce anti-proliferative, immunosuppressive, and anti-inflammatory effects beneficial for psoriasis.
How is methoxsalen absorbed and how long does it last?
Solubilized methoxsalen in gel caps is absorbed rapidly. Older microcrystalline forms are slower, less complete. Fatty foods can slow absorption. There's significant first-pass elimination in the liver. Peak photosensitivity typically occurs 1 to 2 hours after ingestion, but varies. The drug half-life is about 1 hour, but the skin remains sensitive to light for 8 to 12 hours, requiring extended sun protection.
How is it usually given?
Oral methoxsalen is available as 10 milligram capsules, soft gel or hard gel. Dose ranges from 10 to 70 milligrams based on weight, 0.4 to 0.6 milligrams, taken 1.5 to 2 hours before UVA exposure. Taking with food might decrease absorption slightly, but helps minimize nausea.
Can you apply it topically?
Yes, topical PUVA is an option. A 1% methoxsalen lotion is available for topical application for vitiligo. Also, soak bath PUVA involves diluting methoxsalen in bath water for localized palmoplantar use or more diffuse areas, minimizing systemic absorption. And there's an extracorporeal solution for CTCL, which we'll get to.
How effective is PUVA for psoriasis?
Approximately 70% to 100% of psoriatic patients achieve clearing or near clearing within about 24 treatments. Remission typically lasts 3 to 6 months, often needing maintenance therapy.
And vitiligo takes longer.
Much longer commitment. Between 150 and 300 treatments for noticeable results. Localized vitiligo can use topical PUVA. Extensive disease needs systemic. PUVA is also used off-label for atopic dermatitis, alopecia areata, lichen planus, urticaria pigmentosa.
What are the main toxicities?
Acute effect is phototoxicity. Erythema, edema, blistering, itching, basically a severe sunburn. Other acute effects include GI issues, CNS effects, bronchoconstriction, liver toxicity, HSV recurrence, potential retinal damage.
How do you protect the eyes?
Ocular toxicity is largely preventable by diligently wearing UVA-blocking glasses on the day of treatment. Patient education is critical here.
And long-term risks. Skin cancer.
Chronically, the risk of non-melanoma skin cancer is dose-dependent, greatest risk with 200-250 treatments. Conflicting evidence regarding a link between extensive PUVA and melanoma. Pregnancy category risk cannot be ruled out.
Okay, what about photopheresis or ECP? That sounds different.
Extracorporeal photopheresis, ECP, is highly specialized. It involves separating peripheral blood mononuclear cells from the patient's blood via leukapheresis. These isolated cells are then exposed to UVA radiation in the presence of methoxsalen, injected directly into the extracorporeal plasma before being reinfused back into the patient.
So the treatment happens outside the body.
Yes. Once the treated lymphocytes are returned, they undergo apoptosis, programmed cell death, over the next 48 to 72 hours.
What's it used for?
Primarily for cutaneous T-cell lymphoma, CTCL, and off-label for various other T-cell mediated diseases like graft versus host disease, transplant rejection, and scleroderma. It selectively targets problematic immune cells.
How often is it done?
Typically on 2 consecutive days every 2 to 4 weeks, with intervals increased as the patient improves. ECP can also be combined effectively with adjunctive therapies like PUVA, chemotherapy, radiation, biologics, retinoids.
Side effects.
Acute adverse effects can include phototoxic reactions, GI disturbance, hypotension, congestive heart failure. Chronic effects include potential loss of venous access after repeated venipuncture. Pregnancy, evidence of risk in animal studies, no adequate human studies.
And photodynamic therapy, PDT, light plus a drug again.
Yes, PDT combines photosensitizing drugs and visible light. 2 primary drugs for topical PDT, aminolevulinic acid, FDA approved, and methylaminolevulonate approved elsewhere. Both are prodrugs.
Meaning they become active in the body.
Exactly. They are inactive until converted into protoporphyrin IX within living cells.
And then the light activates it.
Correct. In the presence of specific wavelengths of visible light and oxygen, protoporphyrin produces highly reactive oxygen species. These molecules oxidize crucial cellular components like membranes, proteins, mitochondria, ultimately leading to apoptosis of the target cells.
Does it target specific cells?
What's sophisticated is the selective targeting. The epidermis, sebaceous glands, and neoplastic cancer cells tend to accumulate more porphyrin than other skin structures. This preferential accumulation provides a valuable degree of targeted destruction.
What's it approved for?
PDT is approved for precancerous actinic keratosis. It's also used off-label for superficial non-melanoma skin cancers, acne, photorejuvenation, and warts.
What kind of light source?
Both incoherent non-laser light sources like specialized lamps and laser light sources are used. The wavelengths must fall within protoporphyrin's action spectrum and ideally permit maximum skin penetration. Light sources mostly emit energy in the blue part of the spectrum where absorption is maximal, or the red part for better tissue penetration.
And after treatment? Need sun protection?
Yes, because the accumulated porphyrins have a half-life of about 30 hours, patients must diligently protect their skin from sunlight and intense light for at least 48 hours after treatment to prevent significant phototoxic reactions like severe sunburn.
Side effects.
Acute adverse effects are primarily those phototoxic reactions, temporary dyspigmentation, skin color changes, and potential scarring as a chronic effect if treatment is too aggressive. Pregnancy category, risk, cannot be ruled out.
Okay, shifting gears completely. Sunscreens, obviously critical.
Absolutely. Your first line of defense. They provide temporary photoprotection from both acute effects like sunburn and chronic effects like photoaging and skin cancer. They're a critical part of a comprehensive approach, along with minimizing exposure and protective clothing.
They definitely work. Proven effective.
It's well established. Regular and correct use of sunscreen is proven efficacious in reducing photocarcinogenesis and mitigating photoaging. It's vital for long-term skin health.
Explain SPF again. It's mostly UVB, right?
Yeah. Yes. The sun protection factor, SPF, is the ratio of the minimal sunlight dose causing redness with sunscreen to the dose causing the same reaction without sunscreen. Importantly, SPF is primarily a measure of UVB protection and doesn't provide comprehensive info regarding UVA coverage alone. High SPF doesn't automatically mean full spectrum protection.
But newer FDA guidelines address UVA.
Yes, the 2011 guidelines updated labeling and testing. UVA protection is now assessed using the critical wavelength method. Products with a critical wavelength of 370 millimeters or greater can be labeled broad spectrum.
And they can make health claims.
Sunscreens providing broad-spectrum coverage with SPF 15 or greater may include a claim that their use decreases risk of skin cancer and early aging caused by the sun, a significant public health endorsement.
How often should you apply?
Generously, at least every 2 hours. If swimming or sweating heavily, use water-resistant sunscreens and reapply every 40 or 80 minutes, depending on the label. Consistency and reapplication are key.
How do they work? What are the active ingredients? Two main types.
Broadly, yes. First, inorganic agents, or physical blockers. They contain particulate materials that physically scatter or reflect visible UV and infrared radiation, reducing transmission to the skin like a shield.
Zinc oxide and titanium dioxide.
Those are the two inorganic agents available in the U.S. They both provide broad protection, UVA, UVB, even some visible light. Newer microsize and nanosize formulations are less opaque, more cosmetically appealing. A current regulatory consideration is they might become classified as non-generally recognized as safe and effective, non-GRES, by the FDA, meaning they're under review.
And the other type, chemical blockers.
Right. Organic filters or chemical blockers. These agents absorb UV radiation, UVB or UVA, and convert that energy into heat, harmlessly dissipating it.
Lots of different chemicals in this group.
A wide array. Benzophenones like oxybenzone, dibenzoylmethanes, avobenzone, anthrallates, camphors, aminobenzoates, pay-base, cinemates, salicylates, and others like octocrylene. Each offers slightly different protective profiles across the UV spectrum.
Are any of these under review too?
Similar to the inorganics, PABA and trolamine salicylate might also become classified as non-GRACE. PABA has risks of allergic reactions. Trolamine salicylate has risks of anticoagulant effects and salicylate toxicity with widespread use.
And environmental concerns. Coral reefs.
Yes, there is growing concern about potential toxic effects of organic UV filters on marine ecosystems, especially coral reefs. The U.S. National Academy of Sciences is reviewing the science on sunscreen ingredients, their environmental fate, and the public health implications of potential changes in sunscreen usage. It's complex.
Definitely. Okay, let's talk about itch. Antihistamines are common, but itch is more complex than just histamine.
Far more complex. Histamine is potent, a vasodilator, bronchial constrictor, stimulates itch receptors. But itching isn't solely about histamine. Other chemical mediators act as preatogens on C fibers, neuropeptides, prostaglandins, serotonin, acetylcholine, bradykinin.
A whole soup of signals.
And specialized receptors. Yes, specialized receptor systems on cutaneous sensory nerves like vanilloid, opioid, cannabinoid receptors profoundly modulate the sensation of itch. It's incredibly intricate.
And there's a newly discovered pathway involving mast cells.
What's particularly fascinating is the discovery that broad classes of puritogens seem to cause histamine release through direct interaction with MRGPRX2, a mast cell-specific receptor. These systems often act independently of the traditional IgE pathway, opening up novel future targets for antipyretic therapy beyond just antihistamines.
Which histamine receptors are in the skin?
Human skin mast cells express H1, H2, and H4 receptors, but not H3. Both H1 and H2 receptors are involved in wheals, hives, and erythema, redness, but only H1 receptor agonists directly cause pruritus.
So blocking H1 isn't always enough.
Exactly. Blockade of H1 receptors alone does not totally relieve itching in all cases. Sometimes combination therapy with both H1 and H2 antagonists might be superior, suggesting a need to address multiple pathways.
Tell us about the different oral antihistamines, first generation or sedating.
Yes, the first-generation H1 receptor antagonists possess anticholinergic activity and are known for being sedating. Think hydroxyzine, diphenhydramine, promethazine, cyproheptadine. This sedation makes them useful for controlling severe pruritus, especially at night. Doxepin, originally an antidepressant, is also a highly effective oral option.
And topical versions.
A topical formulation of doxepin is available, sometimes used with mild steroids. Its effect is comparable to low-dose oral doxepin. However, allergic contact dermatitis to doxepin can occur. Similarly, OTC topical diphenhydramine also carries a significant risk of causing allergic contact dermatitis.
What about the second generation ones, less sedating?
Correct. The second-generation H1 antagonists, cetirizine, levetiracetam, loratadine, disloratadine, fexofenadine, lack prominent anticholinergic side effects. They're called non-sedating, largely because they don't readily cross the blood-brain barrier, minimizing CNS effects. They're suitable for chronic urticaria, cause fewer adverse effects, and are considered safer overall than the older first-generation drugs.
Okay, now antimicrobials for skin infections, antibiotics. But they have other uses too.
They do. Antibiotics are frequently used for skin and soft tissue infections, SSTIs, but a significant insight is that several antimicrobials like tetracyclines, macrolides, and dapsone also possess significant anti-inflammatory properties.
Ah, that dual action again.
Exactly. This makes them incredibly useful for non-infectious conditions like acne vulgaris, rosacea, certain granulomatous diseases, neutrophilic dermatosis, and even some autoimmune bullous diseases. It dramatically expands their utility.
Topical versus systemic.
Topical agents are highly effective for superficial bacterial infections and acne vulgaris, delivering concentrated drug locally with minimal systemic effects. Systemic antibiotics, oral or IV, are commonly prescribed for more extensive acne or deeper bacterial infections that topicals can't reach.
Acne is the big one for antibiotics.
Arguably the most common dermatological disorder managed with antibiotics. It involves Cutibacterium acnes proliferating in obstructed lipid-rich follicles. C. acnes generates free fatty acids from sebum, interacts with toll-like receptors, promoting microcomedones and inflammation. Suppressing C. acnes with antibiotics correlates with clinical improvement.
What are the common topical antibiotics for acne?
Benzoyl peroxide, clindamycin, topical less common in U.S., erythromycin, and combinations like benzoyl peroxide erythromycin or benzoyl peroxide chloranthromycin.
And using antibiotics alone topically is not recommended.
Generally not recommended for clindamycin or erythromycin monotherapy. Why? Slower onset and significant potential for developing bacterial resistance. Adding benzoyl peroxide or using combination products is strongly recommended to improve efficacy and decrease resistance. Other topicals include azelaic acid, dapso, metronidazole, minocycline, sulfacetamide, sulfacetamate sulfur.
When is systemic therapy used for acne?
For patients with acne that's more extensive or resistant to topical therapy, data support tetracyclines, doxycycline, minocycline, tetracycline, sarecycline, macrolides, azithromycin, erythromycin, and trimethoprim sulfamethoxazole.
How long does it take to work?
Need to manage expectations. 6 to 8 weeks for visible results. Maximum effect sometimes takes 3 to 6 months. Doses are tapered once control is achieved. Using topical benzoyl peroxide alongside systemic antibiotics can further decrease resistance development.
And tetracyclines for acne is more about anti-inflammatory effects.
Their efficacy in acne may be more dependent on their anti-inflammatory activity than direct antibacterial effects. Minocycline, doxycycline, sarecycline have better GI absorption than tetracycline, can be given with food. Minocycline and sarecycline might be less photosensitizing than tetracycline or doxycycline.
Side effects of tetracyclines
Can include vestibular toxicity, dizziness, hyperpigmentation, serum sickness-like reactions, drug-induced lupus. Vaginal candidiasis is common but treatable. Sarecycline's narrower spectrum might lead to less disruption of the microbiome, potentially reducing side effects like candidiasis.
Okay, moving to other bacterial skin infections, treatment depends on the bug and depth.
Absolutely. Numerous organisms can cause cutaneous infections. Clinical presentation and treatment depend heavily on depth, patient's immune status, the specific organism, and local resistance patterns. Gram-positives like Staph aureus and Strep pyogenes are most common. Diabetics or immunosuppressed patients are at higher risk for severe recurrent atypical infections.
Topical therapy for superficial infections, but not on clean surgical wounds.
Frequently used for superficial bacterial infections, wounds, burns. But crucial point, routine use of topical antibiotics on clean surgical wounds without infection signs is generally not recommended. It doesn't reduce infection rates compared to non-antibiotic ointment or nothing, and risks contact dermatitis and selecting resistant bacteria.
Let's talk specific topicals. Mupirocin.
Mupirocin inhibits bacterial protein synthesis, binds isoleucyl tRNA synthetase, effective for psoriasis, including some MRSA and S. pyogenes. Inactive against normal flora or anaerobes. 2% ointment cream, applied 2-3 times daily for 5-10 days. Impetigo, twice daily, 5 days. Nasal form eradicates MRSA nasal colonization, twice daily, 5 days, often with body washes. Repeat monthly courses might suppress MRSA long-term.
Retinoids.
Ritapamilin inhibits protein synthesis at a unique ribosomal site. Active against gram-positives, S. aureus, S. pyogenes, also anaerobes. 1% ointment FDA approved for impetigo-susceptible strains in patients, ELS 9 months. Regimen twice daily for 5 days.
Bacitracin, neomycin, polymyxin B, the common OTC triple antibiotic.
Yes, common in OTC combos, sometimes with hydrocortisone or lidocaine. Bacitracin covers staph, strep, gram-positives. Neomycin covers staph, most gram-negatives. Polymyxin B covers aerobic gram-negatives, including Pseudomonas. However, both bacitracin and neomycin are relatively common causes of allergic contact dermatitis, especially on compromised skin.
Gentamicin, elzonexin.
Gentamicin, aminoglycoside, inhibits 30S ribosome. Activity against some gram-positives, S. aureus, gram-negatives, P. aeruginosa. 0.1% cream ointment applied 3 to 4 times daily. Ozanoxacin, quinolone, inhibits DNA gyrase A to poisomerase IV. Approved for impetigo, S. aureus, S. pyogenes in patients, equals 2 months. 1% cream applied twice daily for 5 days.
Silver sulfadiazine, SSD, for burns.
SSD binds bacterial DNA, inhibits replication. Bactericidal, gram-positives, Infelis MRSA, gram-negatives, Infelis pseudomonas. Most frequent use was partial thickness burns, venous ulcers. However, recent studies fail to show efficacy, may even impede re-epithelialization, rarely argyria, blue-gray skin, with extensive use.
Mafenide, also for burns.
Mafenide acetate, topical sulfonamide, mechanism might differ. Approved as adjunctive therapy for burn wounds, creamer solution. Broad bacteriostatic action, gram-positives, gram-negatives, Instacal, Pseudomonas, some anaerobes. High solubility allows diffusion through eschar. Risk inhibits carbonic anhydrase, potential metabolic acidosis, SPO renal failure, large areas. Other effects, pain burning on application, facial edema, allergic contact dermatitis, rare hemolytic anemia, G6PD deficiency.
And systemic therapy for deeper infections, penicillins, cephalosporins.
Deeper or complicated SSTIs typically require systemic antimicrobials. Superficial infections, if diffuse or non-responsive to topicals, might also need systemics. Since SSTIs are mostly strep staph, penicillins, SBO beta-lactamose resistant, and cephalosporins are used most frequently.
MRSA is a big challenge.
Growing concern, increased incidence of hospital and community-acquired MRSA drug-resistant pneumococci. Common outpatient MRSA options. Clindamycin, doxycycline, trimethoprim, sulfamethoxazole.
What if you need coverage for both MRSA and strep?
Clindamycin alone, or combo of doxycycline or here trimethoprim sulfamethoxazole, plus a beta-lactam. Caveat: don't use clindamycin empirically if local resistance 10-15%.
And for severe complicated SSTIs needing MRSA coverage?
Oral options: linezolid, tidazolid, dilofloxacin, ometacycline. Parenteral options: vancomycin, daptomycin, linezolid, tidazolid, dilofloxacin, ometacycline, ceftaroline, dalbavancin, orativancin, telavancin. A complex arsenal.
Okay, let's switch to antifungals. Very common skin issue.
Extremely common. Fungal infections are among the most frequent skin diseases in the U.S. Numerous effective topical and oral agents exist. We'll focus on common superficial cutaneous mycoses.
Like athlete's foot, jock itch, ringworm, tinea corporis, crus, pedis.
These generally respond well to topical antifungals, includes alamines, naphthafine, terbinafine, benzylamines, butenafines, azoles, iconazole, luliconazole, ciclopirox. Allylamines, benzylamines might provide more sustained cure than azole.
What if there's bacterial infection on top?
Bacterial superinfection can occur with the Taenia pedis. Agents like iconazole, cyclopirox, which have some bacterial coverage, can be useful. Systemic therapy, terbinafine, fluconazole, itraconazole, grizofulvin, used for extensive involvement or poor response to topicals. Systemic ketoconazole not preferred due to liver-heart risks.
What about fungal infections in hair? Taenia capitis.
Dermatophyte infections of hair, Taenia capitis, or follicles, Majaki granuloma, require systemic therapy. Topicals can't penetrate adequately.
Grizofulvin was traditional.
Yes, but treatment failure often due to inadequate dose length. Terbinafine may be more effective for trichophyton tonsurans, the most common U.S. cause. Fluconazole, itraconazole are also effective.
In nail fungus, onychomycosis, needs systemic therapy too.
Most effectively treated with systemic therapy. Crucial to confirm fungal infection before starting oral therapy, about 13 of suspected cases aren't fungal.
Terbinafine is best for dermatophytes.
Most effective. Typical adult dose, 250 milligram daily, 6 weeks fingernails, 12 weeks toenails. Persists in nails after stopping, pulse dosing, for example, 500 milligrams daily 1 week per month for 3 months, studied.
Itraconazole.
Another effective option, even more effective than terbinafine for candida onychomycosis. Also persists long after stopping, 6 to 9 months. Traditional dose, 200 milligrams daily, 6 weeks fingernails, 12 weeks toenails. Pulse dosing alternative, for example, 400 milligrams daily 1 week per month for 2-3 months, may minimize side effects.
Other options.
Fluconazole is an alternative if others can't be used. Grizofulvin, less efficacious, needs longer courses, no longer preferred.
Topical nail antifungals.
Cyclopirox, lacquer, efinaconazole, tavabarol are approved, require very long 48-week treatment. May be useful for mild, moderate cases not involving nail matrix or if systemics contraindicated.
What about candida skin infections? Yeast.
Cutaneous candidiasis, typically treated with topical azoles or no statin if localized. Systemic azoles, fluconazole, itraconazole for recalcitrant severe cases.
Melasezia,
Right.
like pityriasis versicolor or seborrheic dermatitis.
Caused by Melasezia species. Frequently treated with azole cream shampoos. Other topicals. Cyclopirox, terbinafine, selenium sulfide, pyrithione zinc, sodium sulfacetamide, sulfur plus salicylic acid, oral fluconazole, itraconazole, sometimes for diffuser-resistant pityriasis versicolor. Importantly, oral terbinafine does not reach adequate concentrations in superficial stratum corneum to be effective for these Melasezia infections.
Lots of topical antifungals listed in Table 75-9. Polyenes, azoles, allylamines.
Yes, a huge range. Polyenes, nystatin, azoles, clotrimazole, ketoconazole, miconazole, etc. Allylamines, naphthafine, terbinafine, benzylamines, butenafine, hydroxypyridone, cyclopirox, oxabarols, tavabarol, many OTC, plus miscellaneous OTCs like selenium sulfide, gentian violet, tolnaftate, undiselenic acid. Tailored approach needed.
Okay, antiviral agents for skin, HPV, herpes, VZV.
Common infections causing warts or blisters. Systemic agents for HSV, VZV, acyclovir, famciclovir, valacyclovir. For acyclovir-resistant HSV, cidofovir, foscarnet are useful.
Topicals for herpes, like cold sores.
Topically, acyclovir, docosanol, penciclovir, combo acyclovir hydrocortisone are available for mucocutaneous HSV. Important note, these topical treatments are generally less effective than systemic therapies.
What about that buccal tablet?
The unique 50 milligram acyclovir buccal tablet for herpes labialis, applied once to the upper gum above the incisor within 1 hour of prodromal symptoms, the tingle.
What about genital warts from HPV?
Cidofovir used off-label, topically or intralesionally. Topical 1% gel cream via compounding pharmacy. Once daily, 5 days every other week, max 6 cycles. Other treatments, often non-specific cytodestructive therapies. Cryotherapy, podophyllin podophylox, trichloroacetic acid.
Immunotherapies too.
Topical immunomodulatory therapies include imicomod, synecatectins. Intralesional immunotherapy involves injecting things like candida antigen, MMR vaccine, BCG vaccine, PPD, trichophyton antigen, HPV vaccine, interferons. Intralesional systemic may help refractory warts but limited by pain side effects.
Moving on to infestations. Lice and scabies, common and itchy.
Common worldwide, yes. Significant public health impact. Disabling pruritus, secondary infections, body loss transmits typhus. Both topical and oral meds available.
Permethrin is common.
Permethrin, synthetic pyrethroid. Interferes with insect sodium channels, neurotoxicity. Resistance reported increasing, 5% cream RX for scabies, 1% lotion cream rinse, OTC for lice, approved for infants equals 2 months. Other OTC lice agents, pyrethrins, plus piperonal butoxide, acetic acid, plus isopropanol shampoo.
Lindane, second line due to toxicity.
Lindane, organochloride, neuronal hyperstimulation paralysis. FDA labeled second line due to neurotoxicity cases. Highlighted potential neurotoxicity in children, adults 50 kilograms, patients with skin disorders, atopic derm, psoriasis. Contraindicated in premature infants, seizure disorders, boxed warning, medication guide required.
Malathion, flammable.
Malathion. Organophosphate inhibits acetylcholinesterase paralysis death. Approved for head lice, children equal 6. Current lotion formulation, 78% isopropyl alcohol, flammable. Benzyl alcohol, 5% lotion. Approved for lice. Patients equal 6 months. Inhibits lice closing respiratory spiracles. Vehicle obstructs asphyxiation. May lead to less resistance potential.
Ivermectin. Use orally and topically.
Ivermectin, anthelmintic drug. Oral approved for onchocerciasis, strongyloidiasis. Recently, topical 0.5% lotion approved for lice, 1% cream for rosacea. Also effective off-label for scabies. Doesn't cross human blood-brain barrier, so no major CNS toxicity, minor oral side effects, dizziness, somnolence. Topical. Local irritation possible but rare, 1%. Oral dose for scabies lice, 200 jugolkilograms, repeat in 1 week. Crested scabies may need longer cycles plus some topicals. Not for children, 15 kilograms.
Abamectin. Kills eggs too.
Abamectin. Antiparasitic drug approved for head lice 6 months. Pediculocidal and ovicidal activity. Inhibits metalloproteinase is critical for lace egg development. 0.74% lotion applied to dry hair scalp. Left 10 minutes, rinsed. Single application needed due to ovicidal activity, big convenience. Potential side effects: skyny irritation, pruritus, hair color changes.
Spinosad.
Spinosad, 0.9% topical suspension, approved for head lice, 6 months. Causes CNS excitation, muscle contractions, and either paralysis death.
Any less effective treatments still around?
Less effective topicals for scabies lice include 10% crotamitin cream lotion, compounded 5-10% precipitated sulfur in petrolatum. Sulfur may be useful if others contraindicated, not approved. Apply daily, 3 to 5 days.
Antimalarials. Used in dermatology.
Yeah.
That's surprising.
Yes, chloroquine, hydroxychloroquine, quinacrine, used for dermatoses like cutaneous lupus, hydroxychloroquine, FDA approved. Cutaneous dermatomyositis, polymorphous light eruption, porphyria, cutanea tarda, sarcoidosis, hydroxychloroquine, FDA approved.
How do they work for skin conditions?
Exact mechanism uncertain. May involve inhibiting endosomal toll-like receptor signaling, reduced B-cell dendritic cell activation.
Dosages. Special considerations.
Hydroxychloroquine, typically 200 milligrams twice daily, max 6.5 milligram a day. Chloroquine, 250-500 milligram a day, max 3 milligram a day. Quinacrine, 100-200 milligram a day. Patients with porphyria cutanea tarda need lower doses. Avoid hepatotoxicity. Smoking decreases effectiveness in cutaneous lupus. Smoking cessation important. Clinical improvement may take months. Quinacrine can be added if hydroxychloroquine fails after 3 months, compounded in U.S.
Ocular toxicity is a risk.
Dose-dependent ocular toxicity, retina, occurs with chloroquine, hydroxychloroquine, rare non-existent with quinacrine, requires regular eye exams.
Okay, now the heavy hitters. Cytotoxic and immunosuppressant drugs for severe conditions.
Yes, powerful agents used for immunologically mediated diseases like severe psoriasis, autoimmune blistering diseases, leukocytoclastic vasculitis. They inhibit cell growth or suppress the immune system.
Let's start with antimetabolites, methotrexate. Big one for psoriasis.
Methotrexate, a cornerstone for moderate to severe psoriasis, acts as dihydrofolate reductase inhibitor, blocking metabolic pathways for cell proliferation, suppresses immunocompetent cells in skin, decreases expression of certain adhesion molecules, also useful for atopic dermatitis, pityriasis lichenoides, lymphomatoid papulosis, sarcoidosis, pemphigus vulgaris, pityriasis rubra-pilaris, lupus, dermatomyositis, CTCL.
That was a given.
Often combined with phototherapy or other systemics. Regimens: 10-25 milligrams orally once weekly, single dose, or 3 divided doses 12 hours apart, or intramuscular injection 10-25 milligrams once weekly, max 30 milligram a k. FDA approval allows oral, IV, IM, subcutaneous.
Monitoring is critical. Kidney function, drug interactions.
Crucial. Doses decreased for impaired renal clearance. Do not administer with probenecid, trimethoprim, sulfamethoxazole, salicylates, other drugs competing for protein binding. Rhesus levels, toxicity, bone marrow suppression. Fatalities occurred with concurrent NSAIDs, vital medication reconciliation needed.
Bone marrow suppression is a major risk.
Significant anti-proliferative effects on bone marrow. Monitor CBCs serially. Clinicians must know how to use folinic acid, leucovorin rescue, for methotrexate-induced hematological crises.
Liver toxicity too?
Careful monitoring of liver function tests needed. Liver biopsy may be recommended after cumulative dose. 3.54 g low risk, 1.5 g high risk, e.g. obesity, diabetes. Don't use abnormal LFTs, liver disease fibrosis, absolutely contraindicated in pregnancy, lactation, teratogenic. Folic acid, often given routinely to reduce side effects, oral ulcers, GI upset.
What about 5-fluorosil, 5-FU, used topically?
5-FU, primarily used topically for multiple actinic keratosis, actinic cheilitis, Bowen disease. Superficial DCC is not amenable to other treatments. Intralesional injection used off-label, keratoacanthomas, warts, porokeratosis.
How does it work?
Blocks methylation and DNA synthesis, inhibits cell growth proliferation. Typically applied once, twice daily for 2 to 8 weeks. Treated areas become severely inflamed during treatment. Expected usually subsides after stopping.
Alkylating agents. Damage DNA.
Yes, another powerful class, often for severe conditions. Cyclophosphamide. Highly effective cytotoxic immunosuppressive. Oral if used. FDA approved for advanced CTCL. Other uses. Severe autoimmune conditions. Pemphigus, pemphigoid, pyoderma gangrenosum, TAN, vasculitis, scleromyxedema.
How does it work? Dosing.
Alkylates cross-links DNA, disrupts cell division, cell death. Usual oral dose. 2 to 2.5 milligilliard a day divided, often 4-6 week delay in onset. 4E pulse admin may offer lower cumulative dose, decreased bladder cancer risk.
Serious side effects.
Many serious adverse effects. Secondary malignancy risk, e.g. leukemia, myelosuppression. Used only in most severe recalcitrant diseases where other options failed.
Meclorethamine and carmustine. Topical alkylating agents.
Yes, used topically for CTCL. Crucial to monitor CBCs, LFTs. Systemic absorption can occur, bone marrow suppression, hepatitis. Other side effects: allergic contact dermatitis, secondary skin cancers, pigment changes. Carmustine can cause erythema, post-treatment telangiectasias.
Microtubule inhibitors.
Yeah.
Disrupt cell division.
Right. Target machinery for cell division. Vinblastine. Systemic use approved for Kaposi sarcoma, advanced CTCL. Intralesional vinblastine, also used for Kaposi sarcoma, inhibits microtubule formation.
Podophyllin. From a plant.
Podophyllum resin, mixture from Podophyllum peltatum, mandrake. Contains podophyllitoxin, modophylox, active component. Binds microtubules, mitotic arrest in metaphase, stops cell division. Compounded in U.S., 25% resin applied by physician weekly, max 2 to 6 H's, for anogenital warts. Side effects: irritation, ulcers. Do not use in mouth or pregnancy. Systemic absorption risk.
Purified version better? Podophylox.
Generally recommended to replace crude resin with purified podophylox for patient home use. Consistent concentration. 0.5% gel solution applied twice daily, 3 consecutive days. Repeat weekly up to 4 cycles.
Terbinibulin. Newer topical.
Terbinibulin, first-in-class agent, FDA-approved topical for actinic keratosis, face scalp. Inhibits microtubule polymerization plus SRC kinase signaling, disrupts precancerous cell proliferation. 1% ointment applied once daily, 5 consecutive days, up to 25 centimeter site area. Reactions: local skin irritation, pain, pruritus.
Other cytotoxics. Bleomycin.
Bleomycin, used off-label intralesionally, palliated SCC, recalcitrant warts. Systemic, used off-label for Kaposi sarcoma, cytotoxic pro-inflammatory via DNA strand breaks. Side effect: injection into digits, Raynaud phenomenon like vasospasm, also local skin necrosis, flagellate hyperpigmentation.
Liposomal doxorubicin. Ingenol mebutate.
Liposomal anthracyclines, doxorubicin. Maybe first-line monotherapy for advanced Kaposi sarcoma. Ingenol mebutate gel. Extract from Euphorbia peplus, FDA approved for actinic keratosis. Reported to cause rapid mitochondrial swelling apoptosis of dysplastic keratinocytes. Applied once daily, 2-3 consecutive days. Adverse effects: local skin irritation, pain, pruritus infection, periorbital edema, nasopharyngitis, headache, allergic contact derm, herpes zoster reactivation reported.
Okay, what about azathioprine and mycophenolate? Steroids bearing.
Azathioprine, used off-label as steroid-sparing agent for various autoimmune inflammatory dermatoses. Pemphigus, pemphigoid, dermatomyositis, atopic derm, lupus, psoriasis, pyoderma gangrenosum, Besset. Cleave to 6 mercaptopurine metabolites, inhibit de novo purine synthesis. Critical for immune cell proliferation.
Need to test enzyme levels first.
Crucial. Measure thiopurine S-methyltransferase, TPMT, enzyme activity before starting. Low TPMT activity, increased drug toxicity risk. Starting dose 1-2 millikilligan in kilogay. Careful lab monitoring, essential SBO low TPMT to prevent myelosuppression.
Mycophenolate sodium, transplant drugs.
Yes. Immunosuppressants approved for organ rejection prophylaxis. Mycophenolate mofetil prodrug hydrolyzed to mycophenolic acid. Mycophenolate sodium salt in enteric-coated form. Mycophenolic acid inhibits TB lymphocyte activation proliferation, inhibits inosine monophosphate dehydrogenase, reduces GMP synthesis via de novo purine path. Lymphocytes very dependent on this path, may enhance apoptosis.
Used off-label in dermatology.
Increasingly used off-label for inflammatory autoimmune diseases. Dosed 2-3 g day adults or 30-50 mg BD day, PEDs, divided twice daily. Useful as corticosteroid-sparing agent, autoimmune blistering disorders. Also used for psoriasis, atopic derm, pyoderma gangrenosum. Serious side effects, rare. PML, pure red cell aplasia, reported in transplant patients. Most common, dose-dependent GI symptoms, diarrhea, nausea, abdominal pain. Enteric-coated form improves GI tolerability.
Calcineurin inhibitors target T cells. Cyclosporine.
Yes, sophisticated immunosuppressants, cyclosporine, potent, from fungus Tolipocladium inflatum, FDA approved for psoriasis. Modified microemulsion formulation improves bioavailability consistency. Other uses: atopic derm, alopecia areata, epidermolysis bullosa acquisita, pemphigus, pemphigoid, lichen planus, pyoderma gangrenosum. Dose 2.5 mg kidney issues, modified form, divided twice daily.
Major side effects: hypertension, kidney issues.
Yes, hypertension, renal dysfunction are major adverse effects. Minimized by careful monitoring, serum creatinine 30% rise, RCLGFR, dose 5 mg QP. Alternating therapies may reduce toxicity, increase risk of cutaneous, solid organ, lymphoproliferative malignancies, if prior PUVA.
Tacrolimus.
Topical and systemic. Tacrolimus. Available topically for skin disease, also oral injectable. Systemic tacrolimus used off-label, psoriasis, pyoderma gangrenosum, Beset. Systemic side effects: hypertension, nephrotoxicity, neurotoxicity, GI symptoms, hyperglycemia, hyperlipidemia.
Topical formulations for atopic dermatitis.
Topical formulations: 0.03%, 0.1% ointments approved for atopic dermatitis, 0.03% oint bears, 0.1% Oclus 2 Sires, 0.1% Excitin Sires. Other topical uses: intertriginous psoriasis, vitiligo, mucosal lichen planus, GVHD, allergic contact derm, rosacea. Applied twice daily, generally well-tolerated headache, alcohol intolerance, folliculitis, acne, hyperesthesia.
Systemic absorption low topically, except in certain conditions.
Generally very low, decreases as dermatitis resolves. Used with extreme caution in Netherton syndrome, compromised barrier, elevated blood levels possible.
Pimecrolimus cream. Similar.
Pimecrolimus, 1% cream. Approved for atopic dermatitis, equals 2 Sires. Mechanism: side effects similar to tacrolimus. Low to negligible systemic absorption.
How do these compare to topical steroids?
Tacrolimus pimecrolimus approved as second line for short-term intermittent atopic derm, unresponsive intolerant patients. Unlike topical steroids, no risk of skin atrophy. Very useful as steroid-sparing agents or for sensitive sites, eyelids, face, folds, or areas with existing steroid atrophy.
MTO inhibitors. Sirolimus, everolimus, temsirolimus.
Yes, this class includes sirolimus and newer analogues everolimus, temsirolimus. Improved solubility efficacy. Exert immunosuppressive anti-proliferative effects by inhibiting MTOR. Part of PI3 kinase act MTOR pathway, crucial for cell growth, proliferation, survival.
Used in transplant and cancer. What about dermatology?
Established for post-transplant immunosuppression, anti-neoplastic agents, renal hepatocellular carcinoma. Off-label dermatology uses: tuberous sclerosis complex, pachyonychia congenita, complex vascular anomalies, inflammatory dermatosis, systemic sclerosis. Systemic MTOR inhibitors have side effects. Dermatological ones common: stomatitis, mucositis, inflammatory eruptions, nail changes. Topical formulations explored to reduce systemic side effects.
Okay, some unique immunomodulators next.
Imikimod. Boosts local immunity. Imikimod exerts immunomodulatory effects via TLR7 ligand action, induces production of key cytokines, IF-NOT, TNF, IL-1, IL-6, IL-8, IL-10, IL-12, upregulates local immune response. Available as 2.5%, 3.75%, 5% cream.
Approved uses: warts, AKs, BCCs.
5% cream approved for genital warts, 3 WK up to 16 WKs. Also for actinic keratosis, various regimens limit packet scores. 5% cream also for superficial BCCs, 5 WK for 6 WKs. Off-label non-genital warts, molluscum, extramammary, Paget, Bowen disease.
Irritation is common and expected.
Common feature is irritant reactions in virtually all patients. Interestingly, degree of inflammation often parallels therapeutic efficacy, suggests inflammatory response is part of its mechanism.
Xenocatechins. Green tea extract for warts.
Xenotipchins. Partially purified green tea extracts, 85-95% catechins plus other components. Approved topical treatment for external genital perianal warts, immunocompetent patients 18 nerds. Mechanism unclear. Combo antioxidant, antiviral, anti-angiogenic, pro-apoptotic, immunomodulatory activities possible. 15% ointment applied 3x daily up to 16 WKs until clear. Most common side effects: local skin reactions, erythema, pruritus burning, pain, ulceration, edema, peak at 2 to 4 WKs, often encouraged to treat through reactions as tolerated, may indicate response.
Dapsone again, used for anti-inflammatory properties.
Dapsone, utilized in derm primarily for anti-inflammatory properties, is sterile pustular diseases. Acts via multiple pathways, prevents respiratory bursts, suppresses neutrophil migration, inhibits antibody adherence, decreases eicosanoid release effects.
Approved uses, and many off-label.
Approved oral: dermatitis herpetiformis, leprosy; topical: acne vulgaris; extensive off-label uses: linear IgA dermatosis, bullous SLE, erythema elevatum diutinum, subcorneal pustular dermatosis, acne fulminans, pustular psoriasis, lichen planus, Haley, pemphigus, pemphigoid vasculitis, sweet syndrome, granuloma faciale, polychondritis, Bisset, urticarial vasculitis, pyoderma gangrenosum, granuloma annulare.
Dosing. Side effects. Need G6PD check.
Initial oral dose 50 mg day, increased 25 mg day weekly, titrate to minimal effective dose. Key side effects: methemoglobinemia, hemolysis. G6PD level must be checked before starting. Cimetidine can inhibit metabolism, reduce methemoglobinemia risk. Other toxicities: granulocytosis, peripheral neuropathy, psychosis.
Thalidomide. Resurgent drug with serious risks.
Thalidomide, complex history: anti-inflammatory, immunomodulatory, anti-angiogenic. Resurgence in treating various derm diseases. FDA approved for erythema nodosum, leprosy complication. Reported efficacy: actinic prurigo, aphthostomatitis, Bisset, Kaposi sarcoma, cutaneous lupus, prurigo nodularis, uremic prurigo, associated with increased mortality in 10.
And the pterogenicity is the huge issue.
Absolutely critical. In utero exposure, severe limb abnormalities, phocomelia, other anomalies. Never take if pregnant or could become pregnant. May also cause irreversible neuropathy. Use highly restricted RIM-MS program. Newer analogues, lenalidomide, pomalidomide, developed for improved safety.
Now for the really targeted stuff. Biologics for psoriasis and atopic dermatitis. Precision medicine.
Truly a new era. Targeted immunotherapies, including biologics, are rapidly evolving for psoriasis as pathogenesis better understood. Biological therapy for atopic dermatitis also advancing quickly. Major appeal: specifically target T lymphocyte cytokines mediating inflammation, unlike traditional broad immunosuppressant cytotoxics with more side effects.
Psoriasis pathogenesis Th17 pathway is key.
Yes. Chronic immune-mediated inflammatory disorder, innate adaptive systems, abnormal keratinocyte proliferation. Not just skin psoriatic arthritis, systemic manifestations. Previously thought Th1-mediated, now clear Th17 IL-17 pathway plays most significant role. Key targets: IL-23, TNF-A, IL-17. Also JAK inhibitors, PDE inhibitors, decrease inflammatory cytokine expression signaling. S1PR1 modulators evaluated. Regulate lymphocyte traffic in
Atopic dermatitis, barrier dysfunction and immune imbalance. Th2 and Th1.
chronic skin disorder, epidermal barrier dysfunction plus immune-mediated inflammation, often associated asthma, allergic rhinitis. Acute AD, primarily Th2-mediated, cytokines IL-4, IL-5, IL-13. Chronic AD also involve Th1 activity, cytokines IL-12, IFM.
Treatment evolution. Biologics are newer.
Topicals, steroids, calcineurin inhibitors, PDE4 inhibitors, common, mild, moderate. Traditional immunosuppressants for severe resistant. Recently, targeted therapy via IL-4, IL-13 inhibitors, highly efficacious, favorable safety. Additional targets evaluated: IL-31, IL-13, IL-22 inhibitors, S1PR1 modulators. FDA recently approved several JAK inhibitors too.
TNF inhibitors. Block TNF-alpha. Used a lot in psoriasis.
Yes, major class. Blockade of TNF-I reduces inflammation, decreases keratinocyte proliferation, decreases vascular adhesion, improves psoriatic lesions. Risks: significantly alter immune responses, increase risk, serious infection, malignancies. Other: exacerbations, CHF, demyelinating disease, predisposed.
Screening is essential before starting.
Absolutely. All patients carefully screened for TB, active latent, history, demyelinating disorder, cardiac failure, active infection, malignancy. Non-negotiable types: monoclonal antibodies versus TNF-A, adalimumab, certolizumab, infliximab, or soluble TNF receptor, etanercept. All bind soluble membrane TNF. MABs with IgG1-Fc can also activate complement, may explain increased efficacy in granulomatous conditions versus etanercept, also slightly higher infection risk.
Let's cover specific TNF agents.
Etanercept. Soluble recombinant human TNF receptor fusion protein, P75 receptor fused to IgG1-Fc. Binds TNF-A, TNF, approved plaque psoriasis adults, PEDS 4 years, psoriatic arthritis adults, SC Adman, half-life 3 to 5.5 days.
Infliximab, chimeric antibody, 5 infusion.
Infliximab, mouse human chimeric, IgG1 mAb versus human TNF-A. Approved plaque psoriasis, psoriatic arthritis, adults. 4, infusion limiting for some. Onset may be faster, efficacy greater. Potential neutralizing antibodies decreased efficacy. Concomitant methotrexate steroids may suppress antibodies. Half-life 7.7, 9.5 days.
Adalimumab, fully human.
Adalimumab, fully human IgG1 imab versus TNF. Lower risk neutralizing antibodies versus infliximab. Approved plaque psoriasis, psoriatic arthritis, adults. Safety PED psoriasis supported by other uses, JIA. Also approved hidradenitis suppurativa, SC admin, half-life 10-20 days.
Certolizumab pegol, pegylated. Good for pregnancy breastfeeding.
Certolizumab pegol, pegylated fab fragment, humanized mAb versus TNF. Pegylation, delayed elimination, extended half-life. Lacks FC, portion bit, cannot activate complement. Insight, minimal placental transfer or transfer into breast milk, lack of FC. Potential option if treatment needed during pregnancy breastfeeding. Approved plaque psoriasis, psoriatic arthritis, adults, SC admin, half-life 14 days.
Golimumab, mainly psoriatic arthritis.
Golimumab. TNF inhibitor, approved psoriatic arthritis, not psoriasis alone. Those studies showed plaque improvement. Fully human mAb versus TNFM, longer half-life than others.
What about IL-12/23 inhibitors? Ustekinumab?
Ustekinumab, human IgG1 AB versus common P40 subunit of both IL-12, IL-23. Mechanism. IL-12 promotes Th1, TNF, IF no production. IL-23 activates Th17, produce IL-17A, tissue inflammation autoimmunity. Blocking P40 disrupts both pathways. Approved plaque psoriasis, adults, PEDS. 6 years psoriatic arthritis, adults, dosing convenience after weeks 04, given every 12 weeks maintenance. SC admin, half-life 15-45 days.
IL-17 inhibitors, very effective for psoriasis, target keratinocytes.
Yes, direct attack on psoriasis drivers. Keratinocytes, major target for IL-17. IL-17 stimulation, increased keratinocyte inflammatory cytokine expression, epidermal hyperproliferation, barrier dysfunction. Clinical trials show IL-17 inhibitors consistently very efficacious for plaque psoriasis.
Common side effects, specific risks like candida, IBD.
Common. Nasopharyngitis, URI, diarrhea, specific risks, potential increased mucocutaneous candidiasis, yeast infections, risk greater with dual IL-17AF inhibitors. Reports exacerbation, inflammatory bowel disease, IBD, need careful screening.
Specific IL-17 agents, brodalumab, targets the receptor, boxed warning.
Brodalumab, human Ig2 mAb versus IL-17 receptor A, IL-17RA, approved moderate severe plaque psoriasis, adults, antagonizes IL-17RA, inhibits IL-17A, C, D, E, F signaling, boxed warning. Suicidal ideation behavior requires REMS. Studies haven't shown causal link, but monitor carefully. SC admin, half-life 10.9 days.
Bimekizumab, dual IL-17AF inhibitor.
Bimekizumab, humanized IgG1 mAb versus both IL-17A, IL-17F. EMA approved ModSev plaque psoriasis, adults, not currently FDA mAb, target IL-17A alone. SC admin, half-life 17-22 days.
Ixekizumab, secukinumab, target IL-17A. Ixekizumab, humanized IgG4 mAb versus IL-17A, approved ModSev plaque psoriasis, adults, PEDS, and 60s of Rhine, psoriatic arthritis, adults, SC admin, half-life 13 days, secukinumab, fully human IgG1 mAb versus IL-17A, approved ModSev plaque psoriasis, adults, SC admin, half-life 22-31 days.
Phosphodiesterase 4, PDE4 inhibitors, restore CAMP balance.
Yes, another approach. PDE4 enzyme hydrolyzes intracellular CAMP. In psoriasis atopic derm, lesional skin has subnormal CAMP, increased PDE4 activity, increased inflammatory cytokine production. PDE4 inhibition increases intracellular CAMP, decreases expression of inflammatory cytokines. TNF, IF, no, IL-17, IL-23.
Apremilast, oral PDE4 inhibitor.
Apremilast, oral PDE4 inhibitor, approved moderate severe plaque psoriasis, psoriatic arthritis, oral ulcers associated with Behçet disease, adults off-label uses, atopic derm, alopecia areata, hidradenitis suppurativa, lichen planus, cutaneous sarcoidosis, discoid lupus. Most common side effects, weight loss, depression.
Crisaborole.
Topical PDE4B inhibitor for atopic dermatitis, unique chemistry.
Crisaborole. PDE4E inhibitor, approved topical treatment, mild moderate atopic dermatitis. Adults, PEDS, equal 3 months. 2% topical ointment, applied twice daily. Most common side effect, burning, stinging at site. Unique chemistry. Boron-containing benzoxaberol mimics CAMP phosphate, competitively inhibits PDE4. Boron, low molecular weight, 251-day half, facilitates skin penetration.
Roflumilast.
Yeah.
COPD drug studied topically.
Roflumilast, currently approved oral PDE4 inhibitor for COPD. Interestingly, being studied as topical treatment for both psoriasis, atopic dermatitis, shows pathway versatility.
Janus kinase, JAK, inhibitors, intercept cytokine signaling, broad effects.
Yes, JANX are non-receptor tyrosine kinases involved in cytokine receptor signaling. Interact with STATs, activate gene transcription, inflammation, hematopoiesis, wound repair, apoptosis. Inhibition offers treatment for myriad diseases, encapsulated derm, dozens growth factor cytokines, ILs, IFNs, GM-CSF, EPO, GH leptin signal via JEK-STAT. 4 JEKs, JK1, JK2, JK32, YK2, interact selectively with 7 STATs.
Variable selectivity. Approved uses evolving.
Yes, inhibitors vary in JA isoform selectivity, and not all approved for same uses. Landscape growing shifting rapidly. Used alone combo for chronic inflammatory condition, RA, psoriatic arthritis. Recently, atopic dermatitis added.
But there's a big black box warning for oral JAKs. Serious risks.
Crucial safety alert. Study comparing tofacitinib versus anti-TNF noted JK inhibitor use associated with increased risk blood clots, death. FDA issued boxed warning for oral JAKs used chronically, highlights several risks. 1. Increased risk, serious infections, bacterial, fungal, viral, opportunistic hospitalization death. 2. Higher rate all-cause mortality, includes sudden CV death. 3. Higher rate certain cancers. 4. Higher rate CV death, MI stroke. 5. Thrombosis, blood clots. Very serious consideration.
Other side effects. Cholesterol, infections.
Also associated dose-related increases total cholesterol, triglycerides, LDL, share common side effects, URI, viral infections, herpes, headache, nausea, nasopharyngitis, acne. Combining JK inhibitors or with other strong systemic immunosuppressants generally not recommended. Increased risk.
Vaccinations important beforehand.
All age-appropriate vaccinations should be completed prior to therapy.
Yeah.
For prophylactic herpes zoster. Avoid live vaccines immediately prior, during, after therapy. Always use with awareness, latest FDA info, recommended usages, potential adverse reactions.
Specifically JAK agents. Abrocitinib for atopic dermatitis.
Abrocitinib. JAK1 inhibitor, FDA-approved refractory MODSEV atopic dermatitis. Adults, not controlled other systemics. Oral 100 and 200 milligram. 200 milligrams if 100 milligrams inadequate. 50 milligram of moderate kidney failure. Half-life, 5 to 6 H's. Prolonged by CYPP2C19 inhibitors, poor metabolizers. Don't use severe hepatic impairment. Insufficient pregnancy data may impair fertility, reversible. Don't breastfeed during on a day after. Antiplatelet therapies except low-dose aspirin, contraindicated first 3 months, bleeding risk. Recent studies showed safe efficacious in adolescents too, combo topical therapy.
Baricitinib, JAK12, atopic dermatitis, alopecia areata.
Baricitinib, JAK1, JAK2 inhibitor, EMA-approved MODSEV atopic dermatitis. Adults, candidate systemic therapy. Oral 2 milligrams daily, increased to 4 milligrams if inadequate. FDA-approved severe alopecia areata, MODSEV active RA. High-fat meal, slightly decreases absorption. Half-life, 12 H's. Modest hepatic metabolism, CYP3A4. Largely excreted urine unchanged. OET3 inhibitors increase exposure. Also PGP substrate. Use not recommended liver-kidney impairment. Can combine topical steroids, calcineurin inhibitors. Insufficient pregnancy data, don't breastfeed during. Trials ongoing, other indications.
Psoriasis, SLE.
Upadacitinib, JAK1 selective, or APSA, atopic dermatitis. Upadacitinib, JAK1 selective inhibitor, FDA-approved RA, psoriatic arthritis. Indications: extended MODSEV atopic dermatitis, substrate CYP3A4, avoid strong inhibitors, ketoconazole inducers, rifampin. Elimination half-life, 8-14 hours, urine to feces unchanged, some metabolites. May cause fetal harm, effective contraception during 4 WKs after. Breastfeeding not recommended during 6 days after.
Ruxolitinib, systemic and now topical for atopic dermatitis.
Ruxolitinib, JAK12 inhibitor approved systemic therapy, GVHD, myelofibrosis, polycythemia vera. Recently approved topical treatment, short-term, non-continuous, chronic, mild mod atopic dermatitis, immunocompetent 12 cybers, disease not controlled, tops not advisable. 1.5% cream applied thin layer twice daily. Max 60-week 20% BSA. Don't combine therapeutic biologics, other JAK inhibitors, potent immunosuppressants. Insufficient pregnancy breastfeeding data.
Deucravacitinib.
Tofacitinib.
Deucravacitinib, oral selective TYK2 inhibitor in trials for psoriasis. Tofacitinib, oral JAK inhibitor approved RA, PSA, UC, polyarticular JIA, demonstrated efficacy psoriasis trials, atopic derm pilot study.
IL-4 and IL-13 inhibitors. Focusing on atopic dermatitis, IL-13 might be cute, baby.
Transcriptome data shows dominant IL-13 expression versus IL-4 in AD lesions, suggests IL-13 may be more significant driver. Therapies targeting IL-13 or both IL-4-13 emerged, demonstrated efficacy for AD, favorable safety profile. Dupilumab blocks IL-4 receptor alpha. Inhibits both IL-4-13. Dupilumab, fully human IgG4 mAb versus alpha subunit IL-4 receptor, IL-4. Inhibits both IL-4 IL-13 signaling. Both use IL-4 IL-13 Ry1 heterodimer receptor complex. Approved moderate severe AD, adults, peds, except disease not controlled topicals not advisable. Showed significant improvement disease severity, fewer skin infections versus placebo, most frequent adverse effects, conjunctivitis, nasopharyngitis, headache, peripheral eosinophilia, injection site reactions. Some develop drug-associated face neck dermatitis, dupilumab, facial redness.
Tralokinumab binds IL-13 directly.
Tralokinumab human IgG4 mAb selectively binds IL-13, blocks the interaction with IL-13 receptor A1, A2 subunits. Approved moderate severe AD, adults not controlled topicals not advisable. SC injection 600 milligrams week 0, then 300 milligrams Q2 WKs. Patients 100 kilograms achieving almost clear after 16 ROWKs may reduce dose 300 milligrams Q4 WKs. Personalized dosing. Most common adverse effects: URI, headache, injection site reactions, conjunctivitis. Conjunctivitis may be less common severe versus dupilumab.
Lubricizumab also targets IL-13, slightly different binding. Lubricizumab, human IgG4 mAb selectively targets IL-13, prevents formation IL-13-1 IL-4 heterodimer complex, doesn't inhibit IL-13 binding to IL-13-R2 potential decoy receptor. Clinical relevance of this nuance unknown. Currently in trials for AD.
Intravenous immunoglobulin, IVIG, broad immunomodulator from pooled sera.
Yes, IVIG prepared from fractionated pooled human sera, thousands donors, 90% IgG, minimal IgA, soluble CD4, CD8, HLA molecules, cytokines, broad spectrum immune modulating capacity, used off-label in derm as adjuvant rescue therapy, severe conditions, autoimmune blood diseases, 10N, connective tissue diseases, vasculitis, urticaria, severe AD, GVHD.
How does it work? Many proposed mechanisms.
Precise mechanism not fully understood, likely multiple pathways proposed. Suppress IgG production, accelerate IgG catabolism, neutralize complement, neutralize pathogenic antibodies, downregulate inflammatory cytokines, inhibit autoreactive T cells, inhibit immune cell trafficking, block fast ligand-fast receptor interactions for apoptosis. Sheer breadth of potential effects is remarkable.
Contraindications. IgA deficiency.
Contraindicated severe selective IgA deficiency, IgA 0.05 GL. These patients may have anti-IgA antibodies, risk severe anaphylactic reactions, relative contraindications, CHF, renal failure, volume load, potential kidney injury.
Targeted antineoplastic agents for skin cancers. Precision oncology.
Yes, recent advances in understanding molecular pathways, genetic alterations, rapid emergence oncotherapeutics precisely targeted against molecules involved in tumor pathogenesis, often better tolerated than conventional chemo, but adverse effects occur. Cutaneous toxicity is common.
Basal cell carcinoma, BCC. Most common cancer. Hedgehog pathway key.
Yes, BCC, most common human malignancy. UV exposure role, intermittent, intense, cumulative, genital agus, nevoid BCC syndrome, predispose. Usually indolent growth, local destruction, metastasis rare. Nearly all BCCs have aberrant sonic hedgehog pathways signaling persistent activation, uncontrolled basal cell proliferation. Critical target.
Targeted therapies. Smoothened inhibitors. Vismodegib, sonidegib.
Vismodegib, sonidegib. Smoothened inhibitors block hedgehog pathway activation. Approved locally advanced metastatic recurrent disease, not manageable surgery radiation. Also used in avoid BCC syndrome. Most common side effects: muscle spasms, dysgeusia, alopecia, diarrhea. Critical caution. Hedgehog pathway vital fetal development, not extreme caution, women reproductive potential. Men caution potential exposure fetal harm via semen.
Itraconazole has some effect. Semiplimab, PD-1 inhibitor.
Antifungal itraconazole also inhibits hedgehog pathway, limited efficacy versus dedicated inhibitors. Semiflam recombinant human IgG4 mAb inhibits PD-1, releases PD-1 pathway inhibition of immune response. Approved locally advanced BCC previously treated hedgehog inhibitor inappropriate. Side effects: fatigue, musculoskeletal pain, diarrhea, rash, pruritus, URI.
Squamous cell carcinoma, SCC, second most common. UV, immunosuppression risks.
Yes, SCC, second most common skin malignancy. Cumulative UV exposure role, immunosuppression significant risk factor, for example, transplant recipients. Large majority treated surgically, need non-surgical options for high-risk recurrence, nodal or distant metastasis.
Targeted therapies. PD-1 inhibitors again. Semiplimab, pembrolizumab.
Yes, semiplimab, pembrolizumab. PD-1 inhibitors approve recurrent, metastatic, or locally advanced SCC not curable surgery radiation. Unleash immune system versus cancer. Additional off-label options. Traditional chemo, epidermal growth factor inhibitors.
Cutaneous T-cell lymphoma, CTCL.
Yep.
Diverse targeted therapies, HDAC inhibitors.
Complex malignancy. Histone deacetylase inhibitors, varinostat, romidepsin. Approved progressive, persistent, recurrent CTCL refractory other systemic therapies. Exact mechanism uncertain. Inhibit HTAC, may restore tumor suppressor cell cycle, cycle arrest, differentiation, apoptosis, partial response rate 30-35%, complete rare. Side effects, GI symptoms, fatigue, hematological abnormalities.
Alemtuzumab targets CD52.
Alemtuzumab, humanized mAb versus CD52 on many immune cells, TB. Binding neutrophil-mediated antibody-dependent cellular toxicity destroys target cells. Used off-label CTCL, secondary option refractory cases. Common infusion reactions causes prolonged immunosuppression. Opportunistic infections reported at antimicrobial prophylaxis recommended.
Mogamulizumab targets CCR4. Enhanced killing.
Mogamulizumab, defucosylated humanized EG1 mAb, selectively binds CCR4 on regulatory Th2 cells, highly expressed in many malignant T cells. Targets for antibody-dependent cellular cytotoxicity. Defucosylation -50x higher binding affinity. Focoria improved ADCC activation. Approved relapsed refractory mycosis fungoid Sézary syndrome, adult after one prior systemic therapy. Administer slowly 60 min. Monitor infusion reactions can be severe.
Denalucan diftitox, not available U.S.
Denalucan diftitox, fusion protein, diphtheria toxin fragments plus IL-2 receptor binding part. Had FDA boxed warning, serious fatal reactions and capillary leak. Vision loss. Not currently available U.S.
Melanoma, huge advances recently, targeting kinases or immune checkpoints.
Yes, incredible progress. Until recently, metastatic melanoma therapies had low response rates, high toxicity, no survival benefit, rapid development, new options. 1. Inhibition mutated, abnormally activated tyrosine kinases driving tumor growth. 2. Enhancement immune function via immune checkpoint inhibition.
Specific therapies, BRAF/MEK inhibitors, CTLA-4 PD-1 inhibitors.
Therapies include BRAF inhibitors, vimorafenib, dabrafenib, and corafenib. MEK inhibitors, trametinib, cobimetinib, bemabentinib, often combo BRAF plus MEK. CTLA-4 inhibitors, ipilimumab, PD-1 inhibitors, pembrolizumab, nivolumab.
Telamogene laherparifec, TFEC, oncolytic virus.
TVEC, additional novel therapy, unresectable melanoma, oncolytic immunotherapy, derived genetically modified attenuated HSV1, administered intralesional injection, designed selectively replicate within tumors plus produce GM-CSF enhanced systemic anti-tumor immune responses, contraindicate pregnancy, immunosuppressed patients, viral nature.
Okay, back to symptoms. Pruritus, itching. Common, annoying, sometimes sign of systemic disease.
Pervasive symptom, occurs multitude dermatological disorders, xerosis, atopic derm, urticaria, infestations. Also significant sign underlying internal disorders, malignancy, chronic renal failure, hepatobiliary disease. Always needs careful investigation.
Treatment approach involves classifying the type of itch.
Beyond treating underlying disorder, yes. General approach involves classifying into 4 clinical categories. Guides, targeted therapy, table 75-12.
First type, pruritoceptive, originates in skin.
Yes, itch originating in skin, typically due to inflammation in cutaneous disease, agents used. Emollients, repair barrier. Coolants, menthol, camphor, calamine counter-irritants. Capsaicin, counter-irritant, desensitizes nerves. Antihistamines, histamine-induced itch. Topical PDE4 inhibitors, anti-inflammatory, antipyretic. Topical steroids, antipyretic, anti-inflammatory. Other topical immunomodulators, anti-inflammatory. Phototherapy, reduced mast cell reactivity, anti-inflammatory. Thalidomide, anti-inflammatory via TNF suppression. NK1 inhibitors, aprepitant, serlopitant, tradipitant, block NK1 receptor, partial EGFR agonist. Cannabinoids, modulate neurons, anti-inflammatory. Botulinum toxin, inhibit neurotransmitter release. IL-31 inhibitors, inhibit IL-31 receptor signaling on nerves, decrease pruritus, improve barrier.
Second type, neuropathic, from nerve disease itself.
Yes, caused by disease of afferent nerves. Agents used: carbamazepine, blocks synaptic transmission, NAP+ channels. Gabapentin pregabalin, mechanism unclear. Decreased nociceptive transmission via Colici plus channel subunit. Topical anesthetics, EMLA, benzocaine, pramoxine inhibit nerve conduction. Ketamine, NMDA antagonist. Cannabinoids, botulinum toxin.
Third, neurogenic, from nervous system, no clear nerve pathology. Central origin.
Yes, arises from nervous system without clear neural pathology, often related central processes. Agents used: thalidomide, central depressant. Opioid receptor antagonists, naloxone, naltrexone, decrease central opioidergic tone. Tricyclic antidepressants, SSRIs, decrease pruritus signaling via neurotransmitter alteration.
Fourth, psychogenic, due to psychological illness.
Yes, itch directly due to psychological illness. Diagnosis of exclusion. Agents used: anxiolytics, benzodiazepines, relieve stress-reactive pruritus. Antipsychotics, Chlorpromazine, thioridazine, etc. relieve pruritus with impulsive qualities. Tricyclic antidepressants relieve depression, insomnia related to pruritus. SSRIs relieve pruritus with impulsive qualities.
Drugs for hyperkeratotic disorders. Thickened skin. Need to soften.
Yes, conditions with abnormal thickening stratum corneum. Keratolytic agents reduce hyperkeratosis, break down intercellular junctions, increase water content, enhance desquamation, shedding. Common disorders treated: psoriasis, seborrheic dermatitis, cirrhosis, ichthyoses, verrucae, warts.
Specific agents. Alpha-hydroxy acids, AHAs, glycolic, lactic.
Glycolic, lactic, malic, citric, etc. Reduce stratum corneum thickness, solubilize desmosome components, activate hydrolytic enzymes, draw water in durus, facilitate cell separation, also increase GIGs, collagen, elastifibers, and dermis rejuvenation. Widely used photoaging. Glycolic acid use chemical peels, pigmentation, thought inhibit tyrosinase, decrease keratinocyte adhesion. FDA requires sunburn alert label, increase sun sensitivity. Side effects: erythema, desquamation, post-inflammatory hyperpigmentation. Best used adjunctively for refractory epidermal hyperpigmentation.
Salicylic acid. Risk of toxicity.
Salicylic acid solubilizes intercellular cement, reduces keratinocyte adhesion, softens stratum corneum. Critical consideration: potential salicylism, salicylate toxicity, with widespread prolonged use, speech children, renal hepatic impairment. Reported even with 1 to 2% in neonates, multiple daily apps, large area. Chemically not true: beta-hydroxy acid, often listed as such. Sun protection essential, photosensitivity.
Urea. Moisturizer and protein dissolver.
Urea. Low concentrations increase skin water absorption, retention, flexibility, softness. Higher concentrations, 40%, denature dissolved proteins used to solve calluses, avulsed dystrophic nails.
Sulfur. Propylene glycol.
Retinoids again.
Sulfur. Keratolytic, antiseptic, antiparasitic, antiseborrheic. Keratolytic effect via reaction with cysteine, H2S, breaks down keratin. Propylene glycol. 60-90% aqueous solutions. Increases stratum corneum water content. Enhances desquamation. Most effective retention, hyperkeratosis. Retinoids. Stimulate keratinocyte turnover, keratolytic effect, potential skin irritation.
Drugs affecting hair growth. Androgenic alopecia. Male-female pattern baldness. Common. Androgenic alopecia. Most common cause: hair loss, adults, 40 years, increases with age, can start puberty. Genetically inherited variable expression. Mechanism: susceptible follicles, DHT binds androgen receptor, activates genes, transforms terminal follicles to miniaturized vellus follicles, thinning in. Treatment goal: reduce loss, maintain existing hair.
Minoxidil, originally blood pressure drug.
Minoxidil, yes, originally antihypertensive. Noted associated hypertrichosis, excess hair growth, serendipitous discovery. Enhances follicular size, thicker shafts, stimulates, prolongs anagen phase, longer, increased numbers hair. Treatment must be continued indefinitely. Drug-induced growth lost on starving. Insight: patients with increased sulfur-transferase enzyme activity most likely respond. Potential future predictive test. Topical, available 2% solution, 5% solution foam. Side effects: allergic irritant, contact dermatitis. Care applying: hair growth, unwanted locations. Reversible. Wash hands after.
Oral low-dose minoxidil used off-label.
Yes, 0.25 to 5 milligrams daily, off-label. Recommended 0.5 to 0.5 milligrams daily, females, 2.5 milligram daily, males. Most common side effect: hypertrichosis, body, potential systemic, postural hypotension, lower extremity edema, tachycardia, headache.
Finasteride. Inhibits DHT production.
Finasteride inhibits type 2 fiber reductase, converts testosterone mass DHT. Balding areas have increased DHT, smaller follicles. Oral finasteride, 1 milligram a day, variably increases hair growth, men over 2 years. Approved use only in men. Used off-label, female pattern hair loss. Critical teratogenicity. Use in women limited. Pregnant women not exposed, even crushed tablets. Potential genital abnormalities, male fetuses. Side effects: men. Decreased libido, erectile dysfunction, ejaculation disorder, decreased ejaculate volume. Post-marketing reports persistent sexual dysfunction after stopping. New growth lost when med discontinued.
Dutasteride. Broader inhibition. Spironolactone. Anti-androgen.
Dutasteride. Combined type 3 reductase inhibitor, 0.5 mg/day. Similar, greater efficacy versus finasteride. Side effects may be more common. Spironolactone. Aldosterone antagonist diuretic plus anti-androgen activity. Used off-label, female pattern alopecia, 5,200 mg a day. Critical pregnancy caution. Women reproductive potential need reliable contraception, can cause feminization, male fetus.
Other agents. Eflornithine for unwanted facial hair.
Eflornithine. Inhibitor ornithine decarboxylase, ODC rate-limiting enzyme polyamine synthesis, crucial cell proliferation. ODC higher rapidly proliferating cells, follicular matrix and anagen. Inhibiting ODC decreases hair growth. Approved reduction, excessive unwanted facial hair women. 13.9% cream applied twice daily with patient's hair removal method. Slows regrowth.
Bimetoprost for eyelashes.
Glaucoma drug repurposed. Bimetoprost. Prostaglandin analog, approved topical treatment hypertrichosis eyelashes. Increases length, thickness, darkness. Increase eyelash growth, serendipitously noted, use intraocular prostaglandin analogues for glaucoma. Proposed mechanism. Increase fraction hairs in duration of anagen phase. Increase pigmentation via stimulated melanin production. No increased melanocyte number. Important side effect. Brown pigmentation iris. Eyelid skin may occur. Iris pigmentation may be permanent. Key counseling point.
Treatment of hyperpigmentation, dark spots. Need sun protection.
Yes, areas darker than surrounding skin, often excess melanin. Agents most effective: epidermal pigmentation, hormonal light-induced. Limited efficacy: dermal pigmentation. Vital component. Rigorous sun protection avoidance, UV major trigger.
Hydroquinone. Inhibits melanin production.
Hydroquinone decreases melanocyte pigment production, inhibits tyrosinase initial enzyme melanin path, also degrades melanosomes, can destroy melanocytes via reactive oxygen radicals. OTC 1.52%, RX 3.4%. Some formulations have enhancer sunscreens, common effective combo RX, hydroquinone 4% plus fluocinolone 0.01%, mild steroid, plus tretinoin 0.05%. Adverse effects: irritant dermatitis, ochronosis, blue-black permanent discoloration, just for prolonged high concentration use.
Isoleic acid.
Yes.
Less effective than hydroquinone. Dual use.
Isoleic acid, dicarboxylic acid from LSEZ furfur, inhibits tyrosinase, generally less effective than hydroquinone. Dual use. Also mild quetolytic, antimicrobial, anti-inflammatory, used acne, papulopustular rosacea, SPR if post-inflammatory hyperpigmentation present.
Mequinol. Monobenzone causes permanent lightening.
Mequinol, competitive tyrosinase inhibitor, was approved 2% RX combo, 0.01% tretinoin, Vitsi, not currently available. Monobenzone causes permanent depigmentation, destroys melanocytes, not for lutein hyperpigmentation. 20% cream approved final depigmentation, expensive vitiligo, 50% VSA, lightens remaining pigmented skin. Rarely used, not currently available.
Glycolic acid peels again. Tranexamic acid. Used off-label for melasma.
Glycolic acid, AHA, used chemical peels, pigmentation. Inhibits tyrosinase, causes exfoliation. Side effects: erythema, desquamation, post-inflammatory hyperpigmentation. Best adjunctively. Tranexamic acid, synthetic lysine analog, antifibrinolytic. Approved heavy menstrual bleeding, prevent hemorrhage, dental extraction. Fascinating off-label use. Melasma. UV induces plasminogen activator, increased melanogenesis via plasma and arachidonic acid, FGF, plus neovascularization via VEGF. Tranexamic acid mitigates this UV-induced melanogenesis neovascularization, inhibits plasminogen activation. Used topically 2 to 5% twice daily, intradermally 4 mg weekly, monthly, orally 325 milligrams twice daily. Side effects: injection site burning, intradermal, bloating, headache, oral. Screen for thromboembolic risk factors before systemic use.
Finally, some miscellaneous agents.
Capsaicin.
Sheep buffers for pain and itch.
Capsaicin, alkaloid from Solanaceae plants. Interacts TRPV1 receptor C fiber neurons. Chronic exposure first stimulates, then desensitizes channel to capsaicin, other noxious stimuli. Causes local depletion. Substance P, involves sensor pain transmission, analgesic. Cream, lotion, gel, roll-on, patch forms. FDA-approved temporary relief, minor aches, pains, backache, strains, arthritis. Patch RX, postherpetic neuralgia. Off-label, painful diabetic neuropathy, some pruritus.
Bendaquatum. With an ivyberry.
Bendaquatum. Mixture quaternium 18 bentonite plus bentonite clay. Organoclay mixture. FDA-approved OTC topical barrier. Prevent allergic contact dermatitis. Urushiol poison ivy sumac. 5% lotion applied prophylactically 15 minutes prior potential exposure. Reapply Q4 if exposure continues. Creates physical barrier.
Coal tar. Ancient remedy. Complex mixture. For psoriasis, eczema.
Coal tar. Distillation product from coal. Mixture 10,000 compounds. Use derm inflammatory conditions. Psoriasis, seborrheic derm, atopic dermatoma. Mechanism unknown. Known suppressed DNA synthesis. Anti-inflammatory, antimicrobial, antipruritic. Photosensitizing effect. UV visible 330-550 millimeters. Sometimes leveraged therapeutically. Multiple formulations. Crude tar, extracts, solution liquor, carbonous detergents. Use combo UVB phototherapy. Go Heckerman. Salicylic acid, topical steroids. Often poorly tolerated. Odor, mess, staining. Can cause folliculitis, irritant contact derm. Important safety distinction. Occupational exposures linked to malignancies. Studies show topical coal tar treatment, psoriasis topic derm, not associated increased cancer risk.
Anthrol and dithranol, also for psoriasis. Limited use.
Anthril and dithril, synthetic chryserabin from aroba tree bark. Use psoriasis, alopecia areata, mechanisms unclear. Use limited, potential irritant, contact dermatitis, stain, skin, hair, nails, fabrics items.
Bromonidine gel for rosacea redness.
Yeah.
Risk of rebound.
Brimonidine, 0.33% topical gel, adrenergic agonist, FDA approved once daily persistent erythema rosacea. Causes temporary vasoconstriction, reduces redness. Rebound erythema reported some patients.
Oxymetazoline cream, also for rosacea redness, less rebound.
Oxymetazoline, 1% cream. Persistent facial erythema rosacea. Adults, also temporary vasoconstriction. Rebound erythema occurs 1%. Patients suggests more favorable profile versus brimonidine for this issue.
Propranolol and timolol, beta blockers for infantile hemangiomas. Unexpected.
Propranolol, timolol, non-selective adrenergic antagonist, traditionally cardiovascular. Fascinating, unexpected effectiveness treating infantile hemangiomas, benign vascular tumors, infants. Become preferred treatment requiring intervention. Topical timolol drops gels available but don't treat deeper lesions adequately.
And finally, wound healing and scar formation, aiming for regeneration.
Yes, exciting frontier. Normal wound healing, specific engrailed 1, EN1, lineage-positive fibroblasts activated, produce fibrotic scars, lack normal structure components, reduced strength. Challenge. Shift from fibrosis to regeneration.
Tension plays a role. Mechanosensitive signaling.
Yes, tension-activated signaling via cellular mechanosensors drives EN1 expression formation, typical fibrotic scars. Physical forces directly influence outcome.
Inhibitors can change this. Verteporfin, eye drug repurposed.
Yes, specific inhibitors show promise. Verteporfin,
Yes.
benzoporphyrin derivative, PDT photosensitizer eye disease, studied in vitro wound healing via non-photoactivated mechanism. Blocks mechanotransduction, HIPAA pathway, via inhibiting YAP decreased activation EN1 plus fibroblasts. Outcome, permits response EN1 fibroblast, regenerative response, normal skin, strength ultrastructure, without typical scars. Huge leap.
VS6062 inhibits FAK.
VS6062 inhibits focal adhesion kinase, FAK. FAK links mechanical forces, inflammatory signaling fibrosis. Inhibiting FAK disrupts connection, mechanical stress, profibrotic differentiation, fibroblasts. Outcome, faster wound healing, skin regeneration, significantly reduced fibrosis, skin nearly normal mechanical structural properties.
The future is regenerative.
Detailed molecular pathways, scarring, regenerative healing constantly being delineated. Continued progress important not just cosmetic outcomes, but broader fields, tissue repair, regeneration across body. Potential revolutionary breakthroughs.
So what does all of this incredibly detailed and precise information mean for you? We've truly gone on a very deep dive today, uncovering the complex and sophisticated world of dermatological pharmacology. From understanding the very outer layer of your skin to the, intricate cellular signaling pathways that drugs target, it's clear that treating skin conditions is far more nuanced and scientifically advanced than just applying a simple cream.
Absolutely. And if we connect this to the bigger picture, the journey from traditional broad spectrum treatments to the highly targeted immunotherapies, and even the promise of regenerative medicine, it's a profound testament to our deepening understanding of the body's most exposed organ. It highlights the immense progress in tailoring treatments to specific molecular mechanisms, offering renewed hope for conditions previously considered intractable and constantly pushing the boundaries of what's medically possible.
Ultimately, this deep dive is about understanding the why behind the what. Why does a certain cream work on your acne but not your eczema? Why is a particular drug monitored so closely?
Right.
You now possess, hopefully, a foundational understanding of the principles that guide these critical decisions, transforming you into a much more informed and engaged participant in your own skin health journey, capable of appreciating the precision behind your care.
And this exploration inevitably raises an important question, doesn't it? Given the intricate interplay of genetics, individual immune responses, and the dynamic environment that we've touched upon, how might the future of dermatological pharmacology move even further into truly personalized medicine? What new technologies or insights do you foresee emerging that allow us to predict and precisely tailor skin treatments for each individual, moving beyond current classifications to truly bespoke solutions? What's next on the horizon?
That's a great question. The field is constantly evolving, driven by this deep understanding of how our skin works at its most fundamental level. We hope this deep dive has given you a fresh perspective, deepened your professional understanding, and perhaps even sparked some new questions of your own about the incredible, sophisticated science behind dermatological care.